မင်္ဂလာပါရှင်မကြာမီအချိန်တွင် Symposium on Role of NOAC in Thromboembolism အစီအစဉ်လေးစတင်တော့မှာဖြစ်တဲ့အတွက်အသီးသီးနေရာယူပေးကြပါရန်မေတ္တာရက်ခံအပ်ပါတယ်ရှင်ဒီနေ့အစီအစဉ်လေးမှာတော့အခမ်းအနားမှုဖြစ်ကျမဒေါက်တာဝင်းလေးရင်မှတာဝန်ယူဆောင်ရွက်ပေးမှာဖြစ်ပါတယ်ရှင် ABC International Company Limited မှကြီးမှုကျင်းပသော Symposium on Role of NOAC in Thromboembolism ပွဲလေးကိုတက်ရောက်ပေးကြတဲ့ဆရာဆရာမများကိုဦးစွာပထမမင်္ဂလာပါလို့နှုတ်ခွန်းဆက်သအပ်ပါတယ်ရှင် Symposium မစတင်မီမှာအခမ်းအနားစီစဉ်များကိုဖတ်ကြားပေးသွားမှာဖြစ်ပါတယ်အခမ်းအနားစီစဉ်1အရအခမ်းအနားဖွင့်လှစ်ကြောင်းကြေညာခြင်းအစီအစဉ်2 ABC International Company Limited မှ Managing Director Mr. Rajiv Rawal မှအဖွင့်အမှာစကားပြောကြားခြင်းအစီအစဉ်3 India Embassy Counselor Mr. Yadav မှ Perspective on Contribution of India Season 3 India Embassy Counselor Mr. Yadav မှ Perspective on Contribution of India Pharmacy to the Global Health အကြောင်းဆွေးနွေးပေးခြင်း Season 4 Chairperson Professor Dr. မြင့်စိုးဝင်းမှ Atrial Fibrillation and Prevention of Stroke Topic နဲ့ပတ်သက်သောအဖွင့်အမှာစကားပြောကြားခြင်း Season 5 Professor Tia Muralidharan မှ Atrial Fibrillation and Prevention of Stroke အကြောင်းဆွေးနွေးပြောကြားခြင်း Season 6 Chairperson Professor Utin Sulama Clinical Management of Thromboembolism Topic နဲ့ပတ်သက်သောအဖွင့်အမှာစကားပြောကြားခြင်း Season 9 Professor Utai Myan မှ Clinical Management of Thromboembolism အကြောင်းဆွေးနွေးပြောကြားခြင်း Season 10 Professor Thonglin Ngei မှ Act of Anticoagulation Topic နဲ့ပတ်သက်သောအဖွင့်အမှာစကားပြောကြားခြင်း Season 9 Professor အောင်ကျော်သူမှ Act of Anticoagulation အကြောင်းဆွေးနွေးပြောကြားခြင်း Season 10ဆွေးနွေးသားသောအကြောင်းအရာနှင့်ပတ်သက်သည့်မိကွန်းများကို Chairperson နှင့် Speaker များမှပြန်လည်ဖြေကြားခြင်း Season 11 ABC Episab and Product အကြောင်း ABC International Company Limited မှ Group Product Manager မတ်ချိုမေသိန်းမှမိတ်ဆက်ပြောကြားခြင်း Season 12 Chairperson များ Speaker များနှင့်သက်ဆိုင်ရာလူကြီးများအားအမှတ်တရလက်ဆောင်များပေးအပ်ခြင်း Season 13 ABC International Company Limited မှ Executive Director Mr. Dinesh Gandre မှအပိတ်အမှာစကားပြောကြားခြင်း Season 15အမှတ်တရဓာတ်ပုံရိုက်ကူးခြင်း Season 16အခမ်းအနားပြီးဆုံးကြောင်းကြေညာခြင်းတို့ပဲဖြစ်ပါတယ်ရှင်Season 1အရ Symposium on Role of NOAC in Thromboembolism အခမ်းအနားအောင်မြင်စွာဖွင့်လှစ်ကြောင်းကြေညာအပ်ပါတယ်ရှင် Season 2အရ ABC International Company Limited မှ Managing Director Mr. Rajiv Rawal မှအဖွင့်အမှာစကားပြောကြားပေးမှာဖြစ်ပါတယ်ရှင် May I call upon Mr. Rajiv Rawal and please give opening and welcome speech
Good afternoon to all of you. Indeed, a great day today to have all the eminent personalities here with us. And we are grateful to our honorable chairpersons, Professor Minsoben, Professor Twinchilet, and Professor Tholinai, and also the learned speakers, Professor Tenmin, Professor Ong Chotu, who is going to be online, and Professor Muralidharan, for extending all the support and help in organizing this symposium today, and sparing your valuable time and preparing for all these preparations today. On this important subject, NOAC, with extra advantage, introduced for the first time in Myanmar. Professor Muralidharan, we are thankful to you for, putting all those time and efforts in coming here to share all your experience here. We are indeed grateful to you for that. We're also grateful to Mr. R.C. Yadav, the Consular Embassy of India here, for being part of this great symposium today and have his views on the role of Indian pharmaceutical to the global markets. We are indeed grateful to all the august gathering of the doctors here with us today and to have the understanding of this NOAC discussions today. Thank you so much for being with us for yet another blockbuster launch in Myanmar. With this, I just take you to the vision of ABC International, a young dynamic company which was established in 2016 with a vision to bridge the therapy gaps in the country and in the healthcare industry in Myanmar. Today, I can proudly say that we have been standing to our commitments and trying to bridge the therapy gaps in the country. The first ever thing started with in 2016 with the launch of one novel product that was levothyroxine, which is called as T4. That was again the multi-score tablets from Burgo, Argentina, which was one of the first launches for Myanmar. And today, I proudly say that we have almost 70% market share in levothyroxine market or the thyroid market. Thank you, sir. Thank you for being with us for that day. And all your guidance has been grateful for us. Then after that, we launched the second product was a NOAC, which was actually for the treatment of acute bleeding ossifical varices. We are proud to say that we have been able to save many lives with NOAC. Coming to that, after that, we had a lot of biosimilar launches like rituximab, bevacizumab, tocilizumab, and we feel proud that we have been able to bring at very affordable pricing. Today, we feel proud that most of the patients in Myanmar can afford those products which were not very affordable in the country because it was being launched by the innovators. So we were on the generic parts of these products. Now, if you look, today is again another great day for us to launching the product like ABC Apixaban, which is a global blockbuster. I don't mind in sharing that it's something like $18 billion globally. And because of the commercial interest, not any of the multinational could launch the product in the country. And we feel proud that our partners, NATCO, with whom we are marketing this product, has been able to provide this product in this country at a very, very affordable price. We also see that we are going to replace all other NOACs and all in the country. Today, this blockbuster ABC Apixaban is one of the most innovative products from NATCO. So they have been launching not only in Myanmar, in many other countries, and their research center is certainly one of the finest in the global markets. So today is a great day for all of us to be part of this symposium and take the day forward. Thank you so much for being with us. Thank you.
Thank you so much, Mr. Rajiv Rawal. According to Agenda 3, may I call upon Mr. R.C. Yadav to share his perspective on contribution of India pharmacy to global health.
All the distinguished guests from Myanmar, from the healthcare industry, our fellow Indians, and all people who are present over here. Good afternoon and Minglaba. I'm the counselor at Indian Embassy. I have spent only 4 months over here. I'm a soldier turned diplomat. By profession, I'm a brigadier and now deputed to Ministry of External Affairs. And that's how I ended up here as a counselor. And now I'm here to talk about the growth of the Indian pharmaceutical industry. The world is well aware about our success and our prowess about the research and development of the COVID vaccine and catering to not only 1.38 billion population of India through the establishment of 1.5 lakh centers and generating the ecosystem in India to take care of our domestic population, but we also supplied the world over to at least 200 countries. Today, India stands, the pharmaceutical growth in India is around $50 billion, which caters almost 24.6% of export. And we expect to rise to $65 billion by 2024 and around $130 billion by around 2030. All this is courtesy the government incentives which have been given in the form of 21,940 crores in the form of PLI, that is production linked incentives to the manufacturing industry in India. Also, the growth of the medical tourism in India because of the quality and the service which is available in India in the major urban centers, also the large domestic demand from India, and also the largest number of manufacturing plants that is US FDA compliant, which are there in India. It is all contributing to the growth of pharmaceutical industry in India. Today, we are catering to the 20% demand of generic medicines globally, 50% of the African demand, 40% of the American, and 25% of the UK. And catering to 60% demand of the vaccine supply to the entire globe, and WHO 70% requirement is met by the Indian industry. Now coming to the Myanmar, we are catering to around 300 million export for the data of 2021, which is not a very large size. But as a diplomat, what we are focused at, we should not only trade with Myanmar, not only supply, but we should promote the manufacturing of generic medicines even in Myanmar. That should be our focus. And towards that extent, we have already invited several business delegates involved in the pharma industry, and they are coming in Myanmar from 24 to 28 April. We are organizing a business meet in Yangon. Then we are taking them to Tonji, in which there are 2-3 industries who have shown interest, not only for trading, but also for setting up the manufacturing plants over here. That is our focus area. And not only that, we are aware that most of the Myanmar people, they rush to Thailand, they rush to India for their medical treatment. Why can't we have hospitals over here? And we are one of the second largest neighbor, like after China, sharing around 1,600 kilometers of border with shared the history and the cultural linkages. So we want to stand behind Myanmar in development of local hospitals over here in the major cities like Yangon, Mandalay, and other areas, so that the large cross-section of the Myanmar people can also benefit. And then we are also aware about the traditional medicine, like 60-70% of the rural Myanmar, they focus on that. And currently 5 delegates, including the Union Minister of Health from Myanmar, they are going to attend a symposium on traditional medicine in Guwahati happening in the first week of March. So we assure you that we remain committed for the growth and prosperity of Myanmar in the pharmaceutical industry. And we are open to Myanmar people 24/7. And with this, I end my talk, because as a soldier, I should not be talking in the presence of the eminent people from the health industry on these subjects. So I rest my case over here, and thank you so much for the patient hearing.
Thank you so much, Mr. R.D. Yadav. Season Leah, Chairperson, Professor Minso Wema, Atrial Fibrillation and Prevention of Stroke Topic နဲ့ပတ်သက်သောအဖွင့်မှာစကားပြောကြားမှာဖြစ်တဲ့အတွက် Professor Minso Wema ကို symbol သို့ဖိတ်ခေါ်ပါတယ်ရှင်။
Good afternoon, my respected professor, my colleague and distinguished guests. So it is my pleasure to chair the today educational session. The first session is atrial fibrillation and prevention of the stroke. So as we all know, atrial fibrillation affects the 1 to 2% of the total population. The prevalence of AF increased with the age from 0.5 at the 40 to 50 year to 5 to 15% at the 18 years. So the lifetime risk of developing AF is 25% in those who have reached the age of 40. The hemodynamic impairment and thromboembolism event result in significant morbidity and mortality and also the cost of the healthcare. So AF is one of the independent risk factors for acute ischemic stroke. For our ACM patient with the AF, the annual risk of ischemic stroke is around 3.0%. So, oral anticoagulant therapy is the mainstay of treatment in primary and secondary stroke prevention in patients with the atrial fibrillation. As we all know, we have two oral anticoagulant therapy for thromboprophylaxis. One is vitamin K antagonist, and second is non-vitamin K antagonist and NOAC. So as a clinician, we are very keen to know who should take the anticoagulant therapy and which one is suitable for each patient. So today, we have a atrial fibrillation and prevention of the stroke will be presented by our distinguished guest, Professor T.R. Muralidharan. So I would like to introduce our professor. He has a 20-year experience in cardiology. His interest is not only in intervention cardiology, he also expert in electrophysiology and device therapy as well. So he is a membership of fellowship of a lot of the society and so many publication and research activity in his career. Currently, he is a professor and head of the department in cardiology. So may I invite the Professor Muralidharan for your talk, please.
Good afternoon. Am I audible? At the outset, it's a great pleasure to be in this country. It was my long dream to visit this place, though I have seen several parts. A lot I have learned about this country, has a strong relation with this. So it was the moment my friends from NATCO invited me to be here. I said, I really agreed. I said, I want to be another. Yeah. At the outset, I want to thank the ABC International also for making this possible. And like my previous speakers, my distinguished professors, the way they have assembled together today, it's a great day often going to be. For the next 20 or 25 minutes or so, I'm going to cover on the important topic, atrial fibrillation and prevention of stroke. We know it's a global problem. The medical community across the world have declared a war against atrial fibrillation's complication. So no wonder it's appropriate that we call the soldier of repute to come and inaugurate this session. Thank you. Atrial fibrillation and prevention of stroke. I'm going to cover on these following headings. What is the problem, introduction, the magnitude of the problem, stroke and systemic embolism, risk stratification, the available pre-existing drug like vitamin K antagonists or warfarin or acetram, depending on the type of the molecule available in each place, and NOACs, the current drug. Though we call them a newer, they are no more new. Our experience, our familiarity with the drug is quite large, for several years now. So we will see one by one in the next 20 or 25 minutes. So to begin with, hope it works, yeah. This slide I prefer to share. This is one of the earliest ECG machine. Several decades ago, how the ECG was being recorded by using galvanometers, old analog systems. And in 1906, by Einthoven, he presented or published this particular EKG. You can see atrial fibrillation. Maybe this is the first recording of atrial fibrillation in a scientific way, happened in 1906. But today the technology has improved. We have excellent EKG machines. We do have devices. We have Apple phones. We can pick up atrial fibrillation very easily by the patient himself, by the relatives, by the doctors, by the hospitals. So to diagnose atrial fibrillation, it is no more a problem. It's rather easy. Only thing is the mind should look for it. So an irregular rhythm, absence of P wave, irregular conduction to the ventricle, simple things. I'm not going to go to the details of the electrophysiology atrial fibrillation because that's beyond the scope of today's talk. Maybe discussion, we can discuss about it. But the types of atrial fibrillation, one is first diagnosed. We do see very common in our practice. Patient come with first time atrial fibrillation, which will last for a few minutes or few hours or few days, from which he recovers. It may not recur also. That is one subgroup. But we group them after that into several types, paroxysmal, when it lasts for a few hours or maximum 7 days, and it resolves spontaneously or by a cardioversion, either pharmacological or electrical cardioversion. Then comes the persistent one, where it lasts beyond 7 days. Long-standing persistent is one which lasts be up to 12 months or more. Beyond 12 months, we start going long-standing persistent one. And the permanent. Permanent is where the patient decides to continue to live with atrial fibrillation, and the physician also decides, after sufficient attempts, to revert it to sinus rhythm. You call it permanent. So we have paroxysmal, persistent, long-standing persistent, and of course, permanent one. And things which we were using in medical schools 3 decades ago, like lone atrial fibrillation, we would like to discard those terms. Valvular, non-valvular atrial fibrillation largely being discarded because of studies available. We don't use that valvular, non-valvular because it brings in all the valve problems. Rather today, we will need to limit them atrial fibrillation due to a mitral stenosis or with a mechanical prosthetic valve. Any other valve problem we don't want to bring in. So we started terming it as AFib with MS or with mechanical prosthetic valve, and chronic AF also. Don't use the term chronic. Even 3 months atrial fibrillation may be amenable for a good therapy. You can bring back the sinus rhythm. Looking at the epidemiology, this is the 2010 map, where you can see India, your country, Burma, entire the Southeast Asian. We have an incidence from somewhere 325 to 400 per 100,000 population. That's the incidence in 2010. Today, looking at global prevalence, sometime now, 2020, you can see the number is increasing. You can see the number is slowly increasing the entire group from 600 to 699 and somewhere more than 600 also in this region. So within a period of 10 years, the prevalence becoming more and more and the incidence keep on increasing. That's the issue number one. So to put in a nutshell, like my chairperson commented, the risk is going up, like 1 in 3 individuals during their lifetime going to have atrial fibrillation. It is more common in men than women, but both the groups, it increases as they get older, and personal risk factors making them more and more prominent, more and more. So projected increase in AF prevalence is enormous in the next 4 to 5 decades. That is the other problem we see. Coming back to the pathophysiology, looking at what happens. We have 2 things here in front of our in the screen. One is an atrial fibrillation of valvular heart disease. You can see the mitral stenosis, aortic wall also narrowed. Other one is a person with ischemic cardiomyopathy where the valves are normal. So we would like to call this as a non-valvular atrial fibrillation, and this is AFib with mitral stenosis. It's a common thing in our practice to image them carefully to look for clot in the left atrial appendage. Because when there's atrial fibrillation, the presence of clot in the left atrium is going to be a major problem, and recognizing them is important. And things like a 3-dimensional echocardiogram, what you are seeing, reconstruction, you can see the clot very well. You can see the clot very well, very easy to identify with a simple technology. So imaging have come in a long way to help us in identifying the complicated atrial fibrillation, otherwise stroke or systemic embolism. What happens? If a clot from the left atrial appendage moves, it can cause an ischemic stroke, which can go for a hemorrhagic transformation. It can be a mesenteric ischemia, or it can be a peripheral embolism. So it can be a stroke or a systemic embolism, though I am going to limit myself to stroke today. Same thing everywhere. My next speaker is going to talk about how to treat these various problems. So this is one thing: hemorrhagic stroke, ischemic stroke, peripheral embolism, embolism to the major organs like mesentery. And why it is important? When the stroke occurs due to atrial fibrillation, usually the clots are larger. It occurs major vessels, not a branch of the cerebral blood vessels, sometimes the internal carotid artery itself, so causing larger stroke risk of mortality is several bounds high. So risk is very high. So we need to protect it. We need to prevent it. We need to prevent setting of clot in the left atrium in this group of patients. But the major challenge that we have with all the physicians here is when I try to give a blood thinner, when I want to give an anticoagulant, there is a risk of thromboembolism going to come down. At the same time, risk of bleeding going to go up. So I need to strike a balance. I need a drug which is going to work very well in protecting the patient from stroke and systemic embolism. At the same time, not to cause a hemorrhagic stroke. So that is the main aim or challenge that we face. How do we identify? First question is how to identify a patient who is prone for stroke. Over years, we learned that presence of atrial fibrillation per se is not sufficient or not enough to develop a high risk for stroke or systemic embolism, rather comorbidities. So you may have a young person who is up to 30 years, 40 years, 50 years, who may not be having any other comorbids. The risk of stroke going to be very less to the level we may not like to give an anticoagulation. So whom to give anticoagulation? As I said in my previous slide, I need to decide when I give anticoagulation, I should prevent stroke, but prevent bleeding risk also. So the bleeding risk is inherent of the anticoagulant. So I have to choose the patient. So choosing few points, we looked at it. This is an old article by JAMA, 2001, where they said, looking at these factors like cardiac failure, hypertension, age above 75 years, people who are diabetic, and people who already had a stroke or a transient ischemic attack, start giving them a score 1, 2, 3, 4, and stroke alone give 0.2 points. So any person who has a significant multiple comorbidity like this, the risk goes up. So when it crosses 1, immediately the risk goes up. So out of this 5 chairs point, more than 1, you straight away they get qualified for anticoagulation. This is in 2001. Over years, the same risk factor was improved further with data. As we started accumulating the data, we realized that chairs can be extended as chairs VAS score, wherein almost same thing. Again, heart failure, hypertension, age more than 75 years, and age 65 to 74 years were added as additional criteria. And diabetes, as usual, stroke and TA 2 points. We brought in 2 more things, further vascular disease in the form of coronary artery disease or a peripheral arterial disease or even a complex aortic plaque seen by imaging. And then sex category women. This is a current thing we want to follow. So CHARS scoring was the first one to begin with. CHARS was the added thing, where as we realized, even CHARS was score, even a mild more than 1, the risk of stroke per year goes by 2.2%. So we realized, look at CHARS score, identify the patient, plan and give anticoagulation at one side. But as a physician, we would love to know what will be the risk of bleeding the same group. The other score we followed is has blood score, like here, where we look at the various risk categories that can cause, that can make the person prone for bleeding, like hypertension, abnormal renal or liver function, presence of stroke itself, bleeding, labile INRs. So when we are on vitamin K antagonist, elderly people more than 65 and people who are on drugs or alcohol, particularly NSAIDs, you look at the score. When the score increases, the risk of bleeding also goes up. I'd like to draw your attention at this point. Whatever we saw as the points for CHADWA score, same properties do exist with has blood score also. So a physician is challenged with this problem or uncertainty or a practical problem of having the scores which make them prone for clotting will make them prone for bleeding also. So you may have to balance it. That is where we will start looking at drugs. So I want to anticoagulate. The person who needs an anticoagulation do have all the risk factors. But when I start anticoagulation, because of the same risk factor, he is prone for bleeding also. So the drug that was available was warfarin at that time. When the idea opened up, the drug available was warfarin, well-studied drug. Anticoagulation like acetram or warfarin or vitamin K antagonist, several trials came in 90s. You can see all the study trials, barring only CAFA, everything favored giving vitamin K antagonist or warfarin in patient to the level very rare to see in clinical medicine, 64% relative risk reduction as compared to placebo. So in 90s, we were very, very certain, yeah, if there is an atrial fibrillation with comorbidities, I have to give vitamin K antagonist. We knew that, and we have a significant bleeding profile also. Compared to placebo, it was scoring better. So that was the standard. So I want to give a patient when there's atrial fibrillation, adverse score, start him on a vitamin K antagonist. But how much to give? How should I monitor? The idea came in was look at the therapeutic range. Before that, how many of my patients can be given anticoagulation? If you see varying things on a whole by various analysis, only 55% of the patients were eligible for warfarin in the atrial fibrillation. And what do we see in this patient? Majority of the time, they were not in the therapeutic range, particularly Asians. This Garfield AF registry started, particularly in Asians, the number of people who were in the therapeutic range was less than 30%, I think. So we realized we Asians who do need anticoagulation, we could not achieve a therapeutic range. Why this therapeutic range? That word is important, is to make a beneficial effect. I want to give warfarin to make a beneficial effect. The INR, international normalized ratio, should be 2 to 3. If it is below 2, when it touches 1.7 and down, it is not going to work. The risk of stroke increases. Whereas when it crosses 3, crossing 3.5, the risk of bleeding goes up. So the therapeutic range should be between 2 to 3 today in our patients. So if you have a patient, if he's on atrial fibrillation, like particularly we have the mechanical valves or a mitral stenosis, you keep an international normalized ratio or INR between 2 to 3, fine, we can continue, but very, very difficult to maintain this range. That was the problem. You cross it, it is dangerous. It is less than that subtherapeutic, it has no use. We caught in this uncertainty again. So only 50% of the people are eligible, and maintaining a narrow therapeutic was another challenge. So that led to understanding a lot of patients who had stroke were due to either INR fails or INR rises. So either INR is subtherapeutic or over, the risk of stroke rises or the risk of bleeding rises. So we need to balance it again. The other issue, important issue is biggest problem. I said with the bleeding risk, the biggest problem is going to be intracranial bleed. Intracranial hemorrhage is going to be devastating, fatal at times, or a major debilitating illness. Patient may live with a gross hemiplegia or paraplegia forever. So, and particularly that risk is much higher in our group, Asians. We have a very high risk compared to whites and black and Hispanic population. Well proven thing. So, to put in a nutshell, vitamin K warfarin therapy is useful, but very narrow therapeutic window. Lot of dose adjustment, risk of stroke and risk of bleeding always should be borne in mind. There are, of course, genetic variation, metabolism, and interaction with the drugs to drugs and diet also. We know how difficult an acetylene diet to be for a patient to follow. So frequent monitoring, frequent dose adjustment needed, and the long off-life and slow onset and offset action make it an important problem in the perioperative setting. When this patient do need non-cardiac surgery or occasionally even cardiac surgery, adjusting the dosage is going to be a challenging one. So these are the various problems we saw with vitamin K antagonist therapy. So we are looking for new drugs. A drug which can be as good as vitamin K antagonist like warfarin or better than that. There the dawn of new drugs. So management consideration, we know it's an effective treatment, but limited by narrow therapeutic window, frequent monitoring, and patient to maintain time in therapeutic range. That is TTR. The INR should be maintained all the time. And if it is not sustained, the risk is going to be high. I want a new drug. So looking at the mechanisms, I know there's an eminent hematologist going to talk with us. I'm not going to spend a longer time on this, but we were looking for drugs which can act selectively. Like patients with, patients where drugs may act on the only 10A or antithrombin, how they are going to work. We started looking at those drugs. And we knew switching them one or the other is a very easy one, this group, from translation of vitamin K antagonist to NOAC. You have to keep the INR monitoring. As the INR comes below, you can start the NOAC immediately. These are the various drugs came into the market, like warfarin acts at multiple sites, whereas rivaroxaban, apixaban, edoxaban act against the 10A, as they are nicely mentioned, extra, what is the thing, advantage, and thrombin inhibitor, dabigatran. So these are the various drugs we had in this group. What are the 4 drugs? As we saw, 4 drugs came to the market in late 2000s, dabigatran, rivaroxaban, apixaban, edoxaban. For India, our experience is mainly for these drugs, and all these drugs are supported by eminent studies, very well done. Now the textbook for a person who want to do research, relay trial, rocket trial, Aristotle, and Engage TIMI. All these 4 trials, seminal investigation published in New England Journal of Medicine, very useful one. This is a nutshell of looking at the thing. You can see Relay trial, 18,000 patients yearly, Rocket 14,264 patients, Aristotle 18,000, and Engage another 21,000. All these are very carefully done. Look at various dosing, which we'll cover soon. They looked at the metabolic things. One thing they found is they could assess the dosage accurately in those trials. Number 2, they can say what type of dose adjustment to be needed. Much more important is there is no need for a monitoring. As I said, INR to be monitored very carefully when you give warfarin, whereas for NOACs, the monitoring part is not there. Pharmacokinetics and pharmacodynamics are well established. So you decide, you choose the patient, choose the right dose, you can leave it and keep observing the patient. No need to do a cumbersome blood test or looking for an excellent lab to maintain quality to plan the drug. And the results. Relay trial, one of the early trial where they compared dabigatran at 150 million twice daily and or 110 million twice daily compared to warfarin. We saw at 110 million twice daily, it is non-inferior to warfarin. At 150 milligram twice daily, it is superior to warfarin. One of the first drugs to show that there is a new line of drugs, newer oral anticoagulants, which can be better than the existing warfarin at that time. Looking at Rocket trial, again, when they compare rivaroxaban versus warfarin, they saw an excellent improvement with benefit with rivaroxaban compared to warfarin. Then came the other drugs like looking at the apixaban, patients with 5 milligram BD, 21% relative risk reduction in this group, 21% relative risk reduction. And other last one, edoxaban, though we do not have directly familiarity to the drug, we know the trials have shown both low dose and high dose edoxabans are non-inferior to warfarin or even superior. So all these 4 trials establish the role of anticoagulation superiority over the existing vitamin K. How superior? Look at meta-analysis. The meta-analysis, the efficacy of NOAC with the warfarin for stroke prevention. You can see here, significant relative reduction with the forest plot favoring NOAC compared to warfarin. Whether the dose is 150 or Rocket 20 milligram or 5 milligram warfarin and Engage, whatever, we can see for prevention of stroke, it is extremely good. What about prevention of or reduction of the risk, bleeding risk? Again, you see the meta-analysis, safety of NOAC, not only efficacy, safety of NOAC in stroke prevention, the entire spectrum is very good. And you can see the winner seems to be apixaban, the best reduction in bleeding risk. In fact, some of the comments made when all the trials came was, all the drugs seems to be good, but the winner seems to be apixaban because of reduction of the fatal intracranial hemorrhage in this group. So meta-analysis, anticoagulation and balance, as we saw some time back. I want to prevent embolism, at the same time reduce the risk of bleeding. They seem to be favorably placed. Drugs like, particularly like drugs like apixaban seems to be playing an important role in this combination. Of course, other drugs also can be used in this group. Intracranial hemorrhage, the dreaded complication, looking at the particular type of bleeding, again, all the drugs are superior, which apixaban seems to be playing well, and other drugs are also equally effective. So to compare, as a clinician, what do I look for? I want to give a drug to prevent stroke and system embolism, reduce intracranial hemorrhage, reduce death, reduce major bleed. That's my main aim when I give anticoagulation. We have drugs like dabigatran at 110 and 150, rivaroxaban, apixaban. They all seem to be working very well, but the overall winner seems to be apixaban, which seems to have a better profile in all these 4 components: stroke and system embolism, intracranial bleed, death, and major bleed. So stroke prevention in oral anticoagulation, we realize we have come a long way in the last 40 years. Initially, we used only aspirin, 22% relative risk reduction. Then came vitamin K antagonist or warfarin, 38% risk reduction compared to warfarin. Then came NOACs. In addition, we have a 19%. So we have progressed from one drug to the latest one, NOACs. So today the monotherapy with antiplatelet is not recommended because of this. We prefer to use NOACs. And the dosage, as I said, you use 150 milligram or 110 milligram of dabigatran. You reduce the dose in elderly people, more than 80, or when you use concomitantly verapamil or increase the bleeding risk by your AS blood score. Where rivaroxaban, either 20 milligram or 15 milligram, desired by the creatinine clearance. For apixaban, 5 milligram twice daily is the standard dose. You bring down to 2.1 milligram twice daily when any 2 of the following 3 are present. That is, people who are more than 80 years, body weight less than 60 kg, or serum creatinine more than 1.5 milligram. Of the three factors, if any two are present, you reduce the dose to 2.5 milligram BD. So planning the dose is going to be a very, very, very easy one to in patient atrial fibrillation. See the characteristics, evaluate the renal function, liver function also at times, and decide about by seeing the body mass index and the age. So today, the treatment of atrial fibrillation, particularly for stroke prevention, is very simple. If the patient is having already on warfarin extremely well maintained, a small group, as I said, continue, no problem. But if there are patients who do not have mechanical heart valve, who do not have moderate to severe mitral stenosis, when there is atrial fibrillation, first thing is identify the low risk patient. If the patient low risk, what do you mean by low risk? We saw the Chadwa score. Anything less than 0 in men and 1 in women, you call them low risk. If they are having the low risk, no need for any antithrombotic. If the risk is higher, you measure the Chadwa score more than 1 in men, 2 in women, straight away plan for anticoagulation. But of course, have a look at the Has blood score, make appropriate adjustment, modification of the risk, go ahead with anticoagulation. Preferred thing will be oral anticoagulation for regularly in this patient. So this is what, again, given the same nutshell, look at rural moderate mitral stenosis or severe mitral stenosis or mechanical heart valve, estimate the risk, 0, no antiplatelet, no anticoagulant, 1 oral anticoagulant is preferred, more than 2 in women or more than 1 in men, straight away go for oral anticoagulation. NOAC is preferred, then vitamin K, as given this graph. And things like occlusion devices, I am limiting today's talk, they are being used infrequently when nothing is possible in a person with a very high risk. Looking in the last 2-3 minutes, I'm going to cover how to design an elderly population, because the aging population across the world, we have to see what happens in elderly people, chronic kidney disease, patients who have GI bleeding or management of bleeding complications. I'll cover few of these things and stop there for discussion purpose. So first thing is, in elderly population, though they are old, they do deserve good anticoagulation and can be carefully given. You can choose the dose the right way of various drugs, number 1. The preferred thing when you want to get apixaban, think of first choice will be 5 milligram twice daily, provided you satisfy the 3 criteria which we discussed now. Second choice will be dabigatran, rivaroxaban, or edoxaban. Next comes important point, patient with renal failure. We do come across patient with low renal function. The point to learn, as we saw by metabolism, is drugs like apixaban and rivaroxaban are eliminated less by kidneys, majority by hepatic pathway, where drug like dabigatran predominantly eliminated by the kidney. So when there's a renal problem, when the renal function is worsened, you prefer a drug that gets eliminated not through the kidney. So again, we would like to prefer a drug which can be easily given, safely given in patient renal failure. The dose adjustment is given like this. All the drugs are given regular dose as long as the GFR is above 50. But when the GFR starts falling below 50, going up to 30, you look at the various options. For dabigatran, you reduce to 110 milligram many times. For rivaroxaban, bring it to 50 milligram once daily. For edoxaban, 30 milligram. But whereas apixaban, you can continue the same way. You go to 2.5 milligram BD. And when it becomes below 30, and there is no evidence for dabigatran, we don't use it. Rivaroxaban at lower dose can be tried. Edoxaban less frequently, and apixaban can be safely tried. In fact, there is one group, CKD patient who are on dialysis. The only drug we can use apart from warfarin going to be apixaban. That's how we look at it. So patients with end-stage renal disease, we can try all the drugs. You look at the suitability of the patient and decide on that. So these are the important things we have to see when you are choosing the drug. So to conclude, anticoagulation is a necessary requisite in patients with atrial fibrillation, particularly when they have comorbidity, number 1. And second thing is, you choose the drug wisely. We have traveled a long way from my simple aspirin to warfarin to NOAC. We know the drug well. You see the patient, know the profile, look at the hepatic and renal function, age, other thing, decide the type of drug and the dose you have to use. So I'll conclude here. Maybe if the time permits, we can discuss more. Thank you.
Thank you very much, Professor Tia Muralitharan. Season 6 Chairperson Professor Utin Sulema, Clinical Management of Thromboembolism topic နဲ့ပတ်သက်သောအဖွင့်မှာစကားပြောကြားပေးမှာဖြစ်တဲ့အတွက် Chairperson Professor ဦးတင်စီလက်ကို symbol သို့ဖိတ်ခေါ်ပါရရှင်
Good afternoon. I'm Professor Tinsula. I'm an endocrinologist and I'm the president of the Myanmar Diabetes Association. And I'm greatly honored to be one of the chairpersons for this academic symposium on NOAC in the thromboembolisms. And actually, the symposium, it is a high time for us to organize for this kind of symposium for two reasons. Increasing prevalence of thromboembolism in our daily clinical practice, and also availability of the diverse agents on the anticoagulant of the therapeutic agents for the management of thromboembolisms. When we were in UK in 1990s, we used to see deep vein thrombosis, thromboembolism. And when we come back to our country, we rarely saw that kind of thromboembolism in our clinical practice. And we thought that where these kind of thromboembolisms are only common in the temperate zone in UK and other countries, and it is a rare condition in our clinical practice in the tropical country. Now we realize that that assumption was wrong, particularly in the era of the global pandemic, COVID-19. We've been seeing many patients with all kinds of thromboembolism, not only the cerebral thrombosis, but also not only the pulmonary embolism and the deep vein thrombosis, but all kinds of thromboembolism we've been seeing. And it became not only the concern of the specialists like internists, hematologists, or the cardiologists, but also it became concerns for every medical doctors in this country. Because during the COVID period, we used to test D-dimer. And then once it is found to be high, even the general practitioners, family practitioners, they started to prescribe one form or other of the anticoagulants. So thromboembolism, we are seeing increasing number, and also not only the specialists, but also the family practitioners are now daily practice, they are administering those kind of therapeutic agents in their daily clinical practice. And another reason for holding this symposium nowadays is that we are now seeing not only the heparin, but also not only heparin and the warfarin, but also we are seeing many various products like NOACs, apizabin, apizabin, and other dabigatran and other agents in this armamentarium of the therapeutic agent for the thromboembolisms. So it is high time in the presence of presence of emerging evidence on these agents. It is high time for us to update ourselves so that we can deliver our care to our patient safely as well as more efficiently. So this is high time for this symposium. And when the people from ABC come to me to organize this symposium, I advise them to organize this symposium to be very relevant to their clinical practice and not to overwhelm with the theories and the trials, so that all the information delivered today will be relevant to our clinical practice, not only for the family practitioners, but also for us as well. So with that background, we have organized this meeting. As for the second part, where we are, thank you. We are very grateful to our international speakers, Professor Tia Muraji Dharan for a very informative talk, which is actually very useful for us, which benefits us in the making of the clinical decision for our patients. And for the second part, because Professor Mural Muradi Dharan has talked about the atrial fibrillation and stroke specifically. Second talk is going to be on the wider perspective, clinical thromboembolism. So I'm very much, it is with great pleasure, I would like to introduce to the speaker to the audience. But as a matter of fact, he's a well-known, Professor Thamia is a well-known speaker, very renowned physician in this country, and no longer require introduction. But for the sake of formality, I would like to talk briefly about him. Professor Thamia is basically he's an internal physician. He's an internal medicine, internist, but with special interest in the field of endocrinology as well. So he is the General Secretary for the Myanmar Society of Endocrinology and Metabolism, as well as Myanmar Diabetes Association. He is a well-known physician and very good speaker. So I'm sure he will deliver you an important message for your clinical practice. So he will be talking about clinical management of thromboembolisms. Without further ado, I have a great pleasure to call upon the speakers, Professor Thamia. Professor Thamia, ladies and gentlemen, please welcome Professor Thamia.
Thank you very much, Mr. Chairperson, and good afternoon to ladies and gentlemen. It is an honor for me to be a speaker in this eminent symposium. Let me use dual language in this symposium for the convenience of for me as well as for our audience. Today, I would like to discuss about the clinical management of the thromboembolism. So, to start with the main topics, let me remind you what is the thromboembolism. It is very easy. Thrombus and embolism. As you all know, thrombus is a blood clot inside the blood vessel, and embolism is it loose and carried by the bloodstream and block another blood vessel. There is an embolism. What is that? That is a very dangerous condition that can cause damage to the many organs and even death of the patient. So, how many types of the thromboembolism? Very basically, there are two types. One is an arterial, one is a venous. An arterial thromboembolism comes from the heart or the artery, and that this can cause a stroke and the other organ ischemia. Our first speaker has discussed about that. And I would like to discuss about the venous thromboembolism. However, there are so many venous thromboembolism, like the cerebral venous sinus thrombosis or the portal vein thrombosis and the superficial venous thrombosis. But those are different entity, and in our topic, I would like to focus on the DVT and the pulmonary embolism. So let's go to the venous thromboembolism. Is it important? First question. The answer is definitely yes. Why? Venous thromboembolism is a common and important cause of the mortality and morbidity because it can cause about 1 to 2 in 1,000 people per year. However, if your age is more than 80, that incidence will increase up to the 1 in 100. And about 1/3 of the patient with the VTE can go to the pulmonary embolism. And if you have the unprovoked VTE, the recurrent rate is 10%. So before going to discuss about the management of clinical management of the thromboembolism, just to refresh the abbreviation, as you all know, VDE, PE, NOAC, DOAC, and the VKE, because I cannot mention in the long term in all sort of the discussion. So just to remind you, what is the unprovoked and provoked? Provoked VD means there is a risk factor, provoking factor for the venous thromboembolism. Unprovoked means there is no definite risk factor. That I think all of you has known that. And proximal DVD and distal DVD, we can divide at the level of the knee. If the DVD comes in above the level of the knee, that is called as a proximal DVD, and below the knee, that is the distal DVD. And another name is the life-threatening VTE and the limb-threatening VTE. Life-threatening, if the VTE that blocks the lungs, it is a life-threatening. If the VTE can cause a very severe venous occlusion and causing the discoloration, swelling, and cyanosis in the leg, that is cause a limb-threatening VTE. It is called as a phlegmasia ceruleus dolens. And then after the end of the VTE, there is a post-thrombotic syndrome. That is, you can see here, well, all the veins has a one-way valve, and if there is a venous thromboembolism, the valve are damaged, and there is a blood flow through the damaged valve, and that can cause a collection and edema of the affected limbs, and there is a swelling, and that will make the very disfigure and very painful and very distressing to the patient. It is also called as a post-phlebitis syndrome, but the term is now changed to the post-thrombotic syndrome. And in the management of the VTE, there is so many questions and so many gray area, and it is I would like to try to discuss in the very simple and straight way. And the first thing is how can we diagnose a VTE? Question is simple, it is very difficult to answer. And what are the stages in the management of the VTE? And do we need to hospitalize the patient for all patients with the VTE? And do we need the reperfusion therapy or anticoagulation alone? And if we need to use a reperfusion therapy, the thrombolysis therapy, do we need to use a systemic thrombolysis or the catheter-directed thrombolysis? And should we use the injection or should we use the oral anticoagulant? And if we choose to use the oral anticoagulant, which kind of oral anticoagulant, NOAC or VKE? And another option is an IVC filter. Should we use the IVC filter to all sort of patients? And how long should be our treatment plan for the patient with the VTE? And there are so many other questions in the management of the VTE. So let me discuss just the very simple step. When should I suspect PE, pulmonary embolism? If the patient has some of the following symptoms, like the dyspnea, chest pain, pre-syncope or syncope or hemoptysis, with or without any hypoxemia, hypocapnia, hemodynamic instability, and ECG changes. Here, this can be differentiated from the pulmonary pathology. In the patient with the pulmonary pathology, hypoxemia will be associated with the hypercapnia, but in the PE, there will be the hypoxemia as well as a hypocapnia. And with or without the predisposing factor or risk factor for the PE. If the patient has some features, we have to suspect the PE. Okay, now, if we have to face the patient with the suspicious for the PE, what should we do? We have to assess the patient hemodynamic stability. There will be the two kinds of patient. One is a patient with the hemodynamic instability, and another is a patient with the hemodynamic without hemodynamic instability. If the patient has the hemodynamic instability, what should we do? First thing is the bedside transthoracic echocardiography. By doing the bedside transthoracic echocardiography, we can differentiate patient into two kinds. One is an patient with the RV dysfunction, another is a without RV dysfunction. If the patient has a hemodynamic instability with the without RV dysfunction, we should look for the other causes of the shock that is unlikely to be the pulmonary embolism. If the patient has a hemodynamic instability and the RV dysfunction, we have to do the CTPA immediately. So is there any CTPA facility here? If there is no CTPA facility, we have to treat the patient as a high-risk PE. If there is a CTPA facility, we have to do CTPA. And after doing the CTPA, there will be two kinds of patient. One is a CTPA positive. That means that there is a pulmonary embolism. We have to treat the patient with the high-risk PE. If the CTPA is negative, okay, let's look for the other causes of the shock. It is not the pulmonary embolism. So I have discussed about the hemodynamic instability. What is the hemodynamic instability? By definition, there's a three kinds. One is the cardiac resuscitation. Second is the obstetric shock. That is a persistent hypotension. That means the systolic pressure less than 90 or the systolic blood pressure drop of more than 40 millimeter mercury longer than 15 minutes and not caused by the new onset arrhythmia or hypovolemic. Those are the features of the hemodynamic instability. So if the patient has without hemodynamic instability, we have to assess the clinical probability of the pulmonary embolism by doing the prediction rule. And after that, we can differentiate between two groups, high risk of PE or the PE likely and the PE unlikely. If the patient is pulmonary embolism likely, we have to do the CTPA urgently. In the CTPA, if there is no pulmonary embolism, no treatment, and we have to investigate further causes of the dyspnea, chest pain. And if the CTPA is positive, we have to give the treatment. And if the patient has features, PE is less likely, we have to do the D-dimer test. If the D-dimer positive, we have to proceed CTPA. If the CTPA confirmed, we have to give the treatment. If the CTPA show no pulmonary embolism, no need to treat. And look for the other causes of the chest pain and the dyspnea. And the D-dimer test is negative, we don't need to proceed CTPA. So that is the initial assessment for the diagnosis of the pulmonary embolism. And here I have discussed about the prediction rule. In the ESC guideline, they are very, very, very detailed, and they use so many assessment protocol, assessment chat, risk assessment, and they are very detailed. So it's very much precise, but very difficult to use. We have to use the chat in our ward. We have to make the chat list. And with the use of the clinical prediction rule, there is a two level score, PE likely and PE unlikely. By that way, we can proceed the CTPA or that we can proceed to the D-dimer test. And now we have the patient with the acute PE. What should we do? First thing is that we have to give the anticoagulation, and we have to assess the hemodynamic stability. If the patient has a PE with hemodynamic instability, there is a high risk that prefer to the reperfusion treatment and hemodynamic support. And the patient doesn't have the hemodynamic instability, we have to check for the two steps. One is the RV dysfunction, and another is the clinical signs of PE severity assessment. If one of them show that there is some signs of the PE severity or RV dysfunction, that is we have to proceed to the troponin test. If the troponin test is positive, there is an intermediate high risk, and if the troponin test is negative, intermediate low risk. Intermediate high risk patients should be admitted and keep under observation and monitoring, and give the anticoagulation And if there is any deterioration, proceed to the reperfusion therapy. And in the intermediate low risk patient, they should be hospitalized and keep under observation. Many of them can be treated with the anticoagulation alone. If the patient doesn't have the RV dysfunction or the clinical signs of severity, if there is no other reason for hospitalization, they can go back home and with the treatment. If there is some indication for the hospitalization, they have to hospitalize and they give the anticoagulation therapy. So in this assessment, we use the assessment score, PESI, and here is a PESI scoring. So very difficult to memorize. If we have to use this scoring, I think we should make the checklist in our ward, and then we have to check with the checklist and giving the marking and differentiate the patient. This is just for your information. And if there is a 0 point, patient can go back home. This is the American Society of Hematology guideline. That is very simple. They don't use the assessment scoring, but they depend on the clinician very much. And with the patient with the pulmonary embolism, that is an individualized approach. They think about the two factors. One is the disease factor, one is the social factor. In the DVD and PE, is there any massive DVD, or is there any severe PE, or is there any high risk for anticoagulant related bleeding, and is there any major comorbidity or any social factor for the home therapy? If there is no special problem, patient can be treated at home with the anticoagulant therapy. Very simple, very useful. That is the American guideline. And after that, what are the phases in the management of the DVD or PE? In the American Society of Hematology, they divide the treatment course in the 3 portions. One is the initial management that will last for up to 3 weeks. And after that, there will be the primary treatment. After that, we have to do the decision point, whether we should stop anticoagulation or should we continue secondary prevention. That is no definite time limitation. So let's go to the initial management. In the initial management, very simple. We have two groups. One is a DVD only, another is a pulmonary embolism with or without DVD. In the patient with a DVD, we have to differentiate between the uncomplicated or extensive. If the patient is an uncomplicated DVD, we can give the treatment at home. What kind of treatment? Anticoagulant therapy. What kind of anticoagulant therapy? NOAC or DOAC. Which type of NOAC? No special suggestion for anyone, like the Rivaroxaban or Epi7. No. With anyone as you wish, you can use. If the patient has an extensive DVD or the limb-threatening DVD, or if the patient is quite young and the lower risk of the bleeding and increased risk of the severe post-thrombotic syndrome, he or she should be hospitalized and he or he should receive the thrombolysis therapy followed by the anticoagulant therapy. What kind of thrombolysis therapy? Catheter-directed thrombolysis is the best for this kind of patient. Intermediate group. If the patient has a proximal DVD and the significant pre-existing cardiopulmonary disease, but they don't have any limb-threatening or life-threatening, they can be kept in the hospital anticoagulation therapy without the IVC filter and keep monitor. And if there is a deterioration, then we proceed to the rescue thrombolysis therapy. And if the patient is stable, we can continue with the anticoagulant therapy. How about the pulmonary embolism? Very similar. If the patient has a low risk of complication, we can give the treatment at home with the anticoagulant therapy, with the preference for the NOAC, and then no special suggestion for the one NOAC over another. You can use anyone as you like for the management of the PE at home. If the patient has a PE with the hemodynamic compromise or hemodynamic instability, he or she should be hospitalized and he or she should receive the thrombolysis therapy followed by the anticoagulation. And which kind of thrombolysis? In the patient with the PE, systemic thrombolysis is preferred. In the patient with the DVT, catheter-directed thrombolysis is preferred. In the intermediate group, PE without any hemodynamic instability, but he or she has an echo or biomarker compatible with the RV dysfunction, they should be hospitalized and give the anticoagulant therapy and keep under observation. If there is any deterioration, they should proceed to the rescue thrombolysis therapy. So let's discuss on the other side. How about the reperfusion therapy? Previously, I have discussed about on the view of the DVD or PE. Now, I would like to discuss about the treatment point of view. In the reperfusion therapy, there is a systemic thrombolytic therapy or the catheter-directed thrombolysis and the surgical pulmonary embolectomy. For the systemic thrombolysis therapy, we should be use this kind of treatment in the high-risk PE and hemodynamic instability, and the rescue thrombolytic therapy. For the catheter-directed thrombolysis, this should be used in the management of the limb-threatening DVT, not the pulmonary embolism, and for the rescue therapy. If those patients are not suitable for the thrombolysis therapy, and surgical pulmonary embolectomy is indicated. So those are the treatment dosage regime and contraindication. In our country, we are using the streptokinase and RTPA, not the urokinase here. Those are the treatment option, and those are the contraindication. I think most of you know about the contraindication for the thrombolysis therapy. And on the point of the NOAC versus PKA, in the management of the PE and the venous thromboembolism, all the guidelines prefer the NOAC than the VKA. However, before giving the treatment with the NOAC, we have to check the patient whether there is any contraindication to the NOAC. On the this box, in this box is a general contraindication to the anticoagulant therapy. In the yellow box, there is a specific contraindication to the NOAC. For example, like the creatinine clearance less than 30 ml per minute, hepatic diseases with a coagulopathy, antiphospholipid antibody syndrome, moderate to severe mitral stenosis, and the prostatic heart valve, and pregnancy and breastfeeding, and the concomitant treatment with the other interactive drugs. So I think this has been discussed with the first speaker for the creatinine clearance. And how about the IVC filter? IVC filter should be considered in patients with the acute PE with the absolute contraindication to the anticoagulation. In these kind of patients, we cannot use the anticoagulation, so we have to prevent the further thromboembolic phenomena. And in the patient with the anticoagulation, if there is a recurrence of the PE, we have to give the treatment with the IVC filter for the prevention of the further attack of the pulmonary embolism. And all kind of the guidelines do not recommend the routine use of the IVC filter for the management of the PE or the VTE. So let's go to the primary treatment after the initial therapy. It is a continuation of the treatment at the end of the initial treatment here. So routinely, there will be the two kinds of primary treatment, shorter course and the longer course. Many treatment guidelines prefer the shorter course that lasts for the 3 to 6 months. And sometimes there will be the longer course, 6 to 12 months. Here, if the patient has completed the initial management, we have to give the primary treatment. In here, there are 3 categories of the DVT or PE. Unprovoked, provoked. In the provoked with the transient risk factor and the provoked with the chronic risk factor. However, don't worry for that. all the guidelines recommend that you have you should give the shorter course, 3 to 6 month course of the primary treatment for all sort of patient. So ESC 2019 suggests that they don't want to use the provoked or unprovoked watering because there is no difference between the management plan. However, there is some indication for the longer course of the primary treatment. For the selected patient with the provoked by the chronic risk factor, and which can be expected to be improved over time, like the improved mobility with the rehabilitation. In those kinds of patients, the longer course of the anticoagulation will be suitable. Apart from that, there is no difference among the provoked or unprovoked or transient or chronic risk factor. So what are the provoking risk factor for the VTE? There is a chronic, transient, intransient, major, minor. Those are the, I think, those all of you know about the provoked risk factor for the VTE. And so now I will proceed to the secondary prevention. At the end of the primary prevention, we have to decide whether should we continue or should we stop the anticoagulation therapy. So in the secondary prevention stage, those are the questions for the continuation of the secondary prevention. Should we use the prognosis score or should we use the D-dimer assessment? Should we use the Doppler assessment for the continuation of the secondary prevention? And how long should we give the anticoagulation therapy for the patient, and whether it should be given aspirin or the anticoagulant therapy? And if we use the VKA, should we give the standard target or should we give the lower target of the INR for the long-term management? And lower doses of the NOAC or the standard dose of the NOAC, which one should we choose in the management of the secondary prevention stage? In the secondary prevention stage, the problem is that if the patient has an unprovoked DVT or unprovoked PE, we don't know about the definite provoking factor or the risk factor, so we have to continue unlimited time. And some clinicians suggest to use a prognosis score, or some clinicians suggest to use a D-dimer testing, and some clinicians suggest the Doppler assessment during the secondary prevention stage. But all guidelines do not suggest to use these kinds of assessment during the secondary prevention stage. If you have the unprovoked PE or DVT, you have to give the treatment indefinitely. So in the stage of the secondary prevention, the patient category will be three kinds. One is a unprovoked or recurrent DVT or PE indefinite antithrombotic therapy. If we want to give the antithrombotic therapy, which kind? Maybe NOAC or VKA. If you choose a VKA, the target INR should be the standard target 2 to 3. If you give the NOAC, you can decide whether lower dose or the standard dose. It depends on your patient. If the patient has a provoked DVT or PE, and he or she has a chronic risk factor, we have to continue indefinite antithrombotic therapy because the chronic risk factor cannot be relieved. And there is the same protocol for the unprovoked PE or DVT. If the patient has a provoked DVT or PE with the transient risk factor, that can be correctable. If the risk factor is corrected, we can stop anticoagulation. However, here is another disease entity. One is a provoked DVT or PE, which has history of previous provoked DVT or PE with the transient risk factor. Also, in that kind of patient, in that group of patient, if there is a no more provoking factor or the risk factor, we can stop anticoagulation. Although this time is provoked by the transient risk factor, if he or she has a history of previous unprovoked VTE or VTE provoked by the chronic risk factor, we have to continue the antithrombotic therapy. till the provoking factor have to be relieved. And this is another group, breakthrough DVD and PE. During the therapeutic VKA treatment, if the patient is taking the VKA and if he or she develop the breakthrough DVD or PE, we have to check the patient INR. If the patient has the adequate INR, we have to give the low molecular weight heparin. If the patient has a poor INR, we can choose NOAC or the low molecular weight heparin. And those are the other special consideration. In the patient with the DVD and a PE with the stable CAT, stable CVT, when we give the anticoagulant therapy, previous aspirin or antiplatelet therapy should be suspended. However, there is some exception. If the patient has a recent acute coronary event or the coronary intervention, it should be consulted with the cardiologist. And if the patient with the DVT, with or without increase of the PT, well, post-thrombotic syndrome, the guideline that suggests against the routine use of the compression stocking. Rule of the compression stocking is that if the patient has a very much edema and the pain associated with the DVT, the compression stocking can help them. So that is another special group of the VTE. If the patient has a pregnancy and suspected PE, what should we do? So we have to do the D-dimer test and the pre-test probability for the D-dimer test. We have to get the treatment with the low molecular weight heparin and check the chest X-ray and the proximal Doppler ultrasound if the patient has signs suggested for the DVT, and proximal DVT present continue with the low molecular weight heparin at the therapeutic dose. If the proximal DVT is not detected, special investigation for the PE have to be proceed. And if the chest X-ray is normal, CTPA or perfusion lung scan, and if the chest X-ray is abnormal, CTPA is indicated. If the CTPA negative, PE rule out. If the CTPA is positive, we have to give the treatment for the patient with the pregnancy and PE. So now we are completing the secondary prevention. So how do we make the follow-up therapy? After getting the diagnosis of PE, we have to give the anticoagulation therapy. And then after the initial treatment, we proceed to the primary treatment. After that, now we are going to the secondary prevention. And after the 3 to 6 months, we have to check the patient whether there is a dyspnea or functional limitation. If there is no dyspnea or functional limitation, and we have to check the risk factor for the chronic thromboembolic pulmonary hypertension. If there is no feature, we have to focus on the main treatment and should advise the patient if the patient has a symptom, come back again. And after that, if the patient has a symptom like the dyspnea or the functional limitation, we have to do the transthoracic echo to determine the probability of the pulmonary hypertension. If there is a low risk, so we have to check for the alternative causes of the dyspnea. And if there is a risk for the pulmonary hypertension, we have to proceed to the VQ scan. If there is a mismatch perfusion defect, refer to the pulmonary hypertension CT-EPH expert management group for those kinds of patients. So after that, I think many of them have known about the dose of the antithrombotic therapy. I don't need to discuss in detail for that. And after the completion of the dose for the VTE, at the end of my presentation, I want to discuss about the don'ts in the management of the VTE or the PE. In the diagnosis, do not measure the D-dimer routinely patient with the high clinical probability. It does not safely exclude the PE. And if the patient with the PE confirmed by the CTPA do not perform the CT venogram, it doesn't need, and do not perform the MRA to rule out the PE. The standard investigation is a CTPA. In the initial phase of the management, in the patient with the renal impairment and antiphospholipid antibody syndrome, do not use the NOAC, even though all guidelines suggest the NOAC over the VKA. Those are the contraindication to the NOAC use. And do not routinely administer systemic thrombolysis as a primary treatment in patient with an intermediate or low risk PE. That is only indicated in the patient with a high risk PE. Do not routinely use the inferior vena cava theta for all kinds of patients. It is only meant for the patient contraindicated to the antithrombotic therapy or in the patient with the recurrent PE. For the patient with the PE in pregnancy, do not insert the spinal or epidural needle within 24 hours of the last dose of the low molecular weight heparin, and do not administer low molecular weight heparin within 4 hours of the removal of the epidural catheter, and do not use the NOAC during the pregnancy and lactation. So today I have discussed about the do's and don'ts for the VDE and PE. Thank you very much for your kind attention.
Season 8 အရ Chairperson Professor ထွန်းလင်းငိမ်းမှ Act of Anticoagulation အကြောင်းအဖွင့်မှာစကားပြောကြားမှာဖြစ်တဲ့အတွက်ဆရာကိုဖိတ်ခေါ်ပါရရှင်
Good evening, all my teachers, my seniors, and all my colleagues. I'm great pleasure to have the chair in this, the last but not the least, important section on today's symposium of role of NOAC in thromboembolism. For proper use of the anticoagulant therapy is important for the every clinicians, not only for their specialties. The arts of balance on use of the anticoagulant between the thrombosis and bleeding risk should be adjusted. On the proper use of the anticoagulants or use on the thromboembolism, thrombosis, that whenever you use the anticoagulant therapy, then you need to consider the risks of bleeding as well as the thrombosis risks. So today, our last speaker, the Professor Aung Cho Tu, he is a professor at head, Department of Medicine, Tangji, and he is also the husband of my colleagues, the hematologist, Professor at head in University of Medicine 1. So he will discuss about the anticoagulant therapy, the art of adjustment. But please accept my apology for he cannot come here in person. Then he will be discussed in virtually on this last topics. Welcome to Professor Aung Cho Tu.
Good afternoon, Mr. Chairman and honorable participants. Thanks, sir, for your kind introductions. It's indeed a great pleasure and honor for me to participate in this webinar along with great chairmen and speakers. I hope that my presentation will be thought-provoking after very informative talks of previous speakers. Again, sorry. Again, thanks ABC International for the opportunity to join this webinar with all of you today. First of all, for the sake of better communications, may I humbly request to allow using bilingual language. Medicine at la sign la sura the paraservus so Kokalo, the Renaissance Kika, most influential medical scientist. And to Biora medicine arts lab, science lab, တကယ်တော့ science universal application ကိုယူရတဲ့အချိန်မှာ arts ကတော့ဒီ practice နဲ့ဆိုင်ပါတယ်အဲ့လိုပဲ science ကဒီ experiment နဲ့ဆိုင်တဲ့အချိန်မှာ arts ကတော့ practice နဲ့ဆိုင်ပါတယ်ဆိုလိုတာက anticoagulants က science နဲ့ဆိုင်ပြီးနဲ့လူနာကို anticoagulant ပေးခြင်းကတော့ practice လည်းဖြစ်တယ် personalize လည်းဖြစ်เสียလို့တဲ့အတွက် arts လို့ရည်ရတာပဲဖြစ်ပါတယ်တကယ်တော့ anticoagulant ပေးခြင်းဆိုတဲ့ arts ကတော့အကောင်းဆိုးအကြောင်းအကျိုးချင့်ချိန်ဝေဖန်ပြီးတော့လူနာနဲ့ဆေးတွန့်တော်အောင်ပေးခြင်းဆိုတဲ့ arts of adjustment ပါပဲရှေ့က speaker ဆရာကြီးတွေကတော့မှတ်ဆရာအဓိကထားပြောပြီးတဲ့နောက်ကျွန်တော်ကတော့တွေးစရာ thought provoking ဖြစ်စရာအဓိကထားဆွေးနွေးရမယ်လို့ထင်ပါတယ်ကျွန်တော်အဲ့ဒါလေးကိုပဲအဓိက focus လုပ်သွားမှာဖြစ်ပါတယ်ပထမဆုံး adjustment ကတော့ defense နဲ့ danger ကြားမှာပဲဖြစ်ပါတယ်အဲ့ဒါကတော့တွေးတိတ်ခြင်းနဲ့တွေးခဲခြင်းကြားမျှခြေအောင်ထားရတဲ့ physiological condition ကိုပြောတာပဲဖြစ်ပါတယ်တကယ်တော့တွေးတိတ်ခြင်းခန္ဓာကိုယ်မှာရေးခြင်း defense mechanism ဖြစ်ပါတယ်ဘာလို့ရေးကြည့်တာလဲဆိုတော့ပုံမှန်အခြေအနေမှာတော့ဒီလိုမျိုးသွေးကြောသေးလေးတွေကပေါက်ကွဲထွက်နေတော့ဒီဥစ္စာတွေကိုအပေါက်ကိုဖာဖို့အတွက် platelets တွေကလာကြတာဖြစ်ပါတယ်ဒီ platelet တွေရောက်လာတဲ့အခါမှာသူတို့ကအပေါက်ကလေးကိုဆိုပိတ်တယ်ဒါပေမဲ့အဲ့ဒါကိုဒီလိုသွေးကြပြအစုအတွဲလေးတွေကိုမြဲဖို့ရာ clotting factor တွေကဖြစ်တဲ့ fibrin strand လေးကနေလာပြီးတော့ခြေရပါတယ်အဲ့ဒါမှပဲ stabilize clots ဖြစ်ပြီးတော့ stop bleeding ကိုဖြစ်စေတာဖြစ်ပါတယ်အဲ့တော့ပထမဆုံးစပြီးတော့ဖြစ်တဲ့ platelet activation ဒီသွေးကြပြစပြီးတော့ activation ဖြစ်တဲ့အခြေအနေလေးကိုတင်ပြလိုပါတယ်သွေးကြောပေါက်တော့အောက်က tissue တွေက expose ဖြစ်လာပါတယ်အဲ့မှာ collagen တို့ bone repair factor တို့ဒီအနီလေးတွေက bone repair factor ပါဒီ bone repair factor လေးတွေက collagen နဲ့ platelet မှာရှိတဲ့သူ့ရဲ့ receptor ကိုချိတ်ပေးလိုက်ပါတယ်အဲ့လိုချိတ်ပြီးတဲ့နောက်မှာတော့ platelet ကသူ activated ဖြစ်သွားပါတယ် activated platelets ကဒီလိုမျိုး dendritic ပုံပြောင်းသွားပါတယ်အဲ့လိုပုံပြောင်းရတဲ့ဒီပိုင်းနဲ့သူရှိမှရှိတဲ့ platelets granules လေးတွေကို release လုပ်ပါတယ်ဒီတခုကတော့ဒီ adenosine diphosphate လေးတွေပါပဲသူတို့က adenosine receptor ကိုတော့ပေါင်းပြီးတဲ့အခါမှာ platelet အချင်းချင်းက aggregation ဖြစ်စေပါတယ်ဒါက platelet တွေကိုစုရအပြင်နောက်ထပ်ဆွဲခေါ်ပါသေးတယ်အဲ့ဒါကတော့သူတို့ကနောက်ထပ် platelet တွေကိုရောက်လာအောင်ပြန်ထပ်ပြီးတော့ recruit လုပ်ပါတယ်အဲ့ခါကျ platelet အစုဝေးဖြစ်ပါတယ်ATP အပြင်သူတို့က thrombocyte တွေပုံမှန်များတဲ့အတိုင်းထုတ်ပါသေးတယ်ဒီ thrombocyte ကလည်းဒီ platelet အချင်းချင်းကို clamp ဖြစ်စေတာပဲဖြစ်ပါတယ်ဒါကြောင့်ဒီကျွန်တော်တို့လက်တွေ့မှာလည်း ATP receptor blocker တို့ thrombocyte pathway inhibitor တို့ဆိုတဲ့ antiplatelet တွေကသွေးမခဲဖို့သုံးကြတာပဲဖြစ်ပါတယ်ဒီလို platelet အစုအခဲဖြစ်ပြီးတဲ့အခါမှာဆက်ပြီးတော့ဆွဲမြဲပြီးတော့သွေးကြောတန်ရာပေါက်တဲ့နေရာမှာတေချာရှည်ကြာစွာစိုးပိတ်နိုင်ဖို့နောက်တစ်ဆင့်တစ်ခုကတော့ coagulation ဖြစ်မှုပါပဲသူကတော့အဆင့်ဆက်ဖြစ်ရတာပါဒီမှာဆိုရင် coagulation pathway မှာ tissue factor က factor 7နဲ့ပေါင်းပြီးတော့ activated ဖြစ်သွားတဲ့ပုံလေးပါနောက်ပြီးဆုံးမှာတော့သူက factor 10မှာလာပြီးတော့ဆုံးပါတယ်ဒါကတော့ intrinsic pathway ပေါ့နောက်ထပ် intrinsic pathway မှာလည်း factor 12စသည်ဖြင့် factor တွေအသီးသီးကအဆင့် activation ဖြစ်ကြပါတယ်သူတို့တွေကလည်းဒီ intrinsic pathway ကလည်းနောက်ပြီးဆုံးမှာတော့ factor 10မှာလာဆုံးပါတယ်ဆိုလိုတာက factor 10 စာ common pathway မှာရှိတဲ့အရေးကြီးတဲ့ factor တစ်ခုဆိုတာလေးကိုကြိုပြီးတော့ information ပေးလို့တာပဲဖြစ်ပါတယ်ဒီလိုမျိုး pivotal pathway မှာရှိတဲ့ဒါ factor 10 လေးပါအဲ့တော့ဒီ factor 10 ကပြီးလို့ရှိရင် in the presence of activated factor 5 မှာ prothrombin ကိုသူက thrombin ဖြစ်ပြောင်းပေးပါတယ်ဒီ factor 10 molecule တစ်ခုက prothrombin molecule ထောင်ချီပြီးတော့ပြောင်းနိုင်တဲ့အတွက်အဲ့ဒါကို thrombin bus လို့တင်စားကြပါတယ်ဒီ thrombin ကတကယ်တော့ဒီလို coagulation cascade မှာပါတဲ့ပြင်သူက platelet တွေကိုလည်းသူကသွားပြီးတော့လှုံ့ဆော်ပါတယ်ဒီအချက်ကလေးကကျွန်တော်ထောက်ပြလိုတာကဒီ pathway platelet နဲ့ coagulation နှစ်ခုကအပြန်အလှန်ချိတ်ဆက်နေတာကိုပြောချင်တာပါနောက်တစ်ခါ thrombin ကဒီမှာမြင်ရတဲ့အတိုင်း fibrinogen ကို fibrin ဖြစ်ပြောင်းfibrin ပြောင်းပြီးဒီ fibrin strand လေးတွေကခုန platelet အစုအခဲကိုမြဲအောင်ကြိုးအနေနဲ့တွဲပေးတာပဲဖြစ်ပါတယ်ဒါကြောင့်ဒီ coagulation pathway ကိုကျွန်တော် simplify ပြီးတော့ summarize လုပ်ရမလို့ရှိရင်ဖြင့်ဒါကတော့ electron microscope နဲ့မြင်ရမယ့်သွေးခဲလေးပါဒီမှာဆိုရင်ဒါလေးတွေက RBC ဒါလေးတွေက WBC ဒီအညိုလေးတွေက platelets နောက်ဒါ fibrin strand တွေပဲဖြစ်ပါတယ် ဒီမှာဆိုရင်ဒီ stabilize clause ဖြစ်ဖို့ကပထမဆုံး platelet အစုပြီးတော့မှ cross link fibrin လာမယ်ဒီ fibrin ဖြစ်ဖို့က fibrin လိုချင်လိုတယ် fibrin လိုချင်တဲ့ fibrin ဖြစ်ဖို့က thrombin ရှိရမယ်သူ့ကို common path တွေကလာတယ် fetter tank က activate လုပ်တယ်သူတို့ကို extrinsic နဲ့ intrinsic power မှာ initiation နဲ့ propagation အသီးသီးဖြစ်ပြီးတော့လာပြီးတော့ဒီသွေးခဲကိုဖြစ်စေကြတာပါအဲ့တော့ဒီမှာအရေးပါတာ thrombin နဲ့ fetter tank ဆိုတာထပ်ပြီးတော့ emphasize လုပ်လို့ပါတယ်အဲ့တော့ဒီလို hemostasis ဟာတကယ်တော့ခန္ဓာကိုယ်အတွက်မရှိမဖြစ်လိုအပ်တဲ့ defense mechanism ဆိုပေမဲ့သွေးတိတ်တာခန္ဓာကိုယ်အတွက်လိုတာမှန်ပေမဲ့သွေးတိတ်ရမှာဖြစ်တဲ့သွေးခဲကမဖြစ်တဲ့အချိန်မဖြစ်တဲ့နေရာမှာဖြစ်လာရင်တော့ဒါ thrombosis ဖြစ်ပြီးတော့ဒါအန္တရာယ်ဖြစ်လာပါတယ် danger ဖြစ်လာပါတယ်ဒီလိုမျိုးသွေးခဲကသွေးလွှတ်ကြောမှာလည်းဖြစ်နိုင်တယ်သွေးပြတ်ကြောမှာဖြစ်နိုင်တယ်ဘယ်မှာပဲဖြစ်ဖြစ်ဒီအကျိုး coronary syndrome တို့ venous thromboembolism တို့ atrial fibrillation တို့ကြောင့်ဖြစ်တဲ့သွေးခဲတို့ဒါအရင် speaker တွေပြောခဲ့တဲ့ condition တွေအားလုံးရဲ့အခြေခံကတော့ thrombosis ပဲဖြစ်ပါတယ်အဲ့တော့တကယ်တော့အခုဆိုရင်အခုကာလအကြောင်းမျိုးစုံကြောင့်သွေးထွက်ပြီးဒုက္ခရောက်တာရှိနေကြသေးပေမဲ့အရင်နဲ့ဆိုင်တော့ဒါနည်းလာပြီလို့ဆိုရမှာပါပဲဒီနေ့ပြောရင် bleeding ကြောင့်အတိအပြောက်ကနည်းလာပြီဒါပေမဲ့တစ်ဆက်တည်းမှာ thrombosis ကြောင့်ဖြစ်တဲ့အတိအပြောက်ကတဖြည်းပိုများလာတယ်ဆိုတာဒီအထောက်အထားတွေကိုကြည့်ရင်တော့တွေ့နိုင်ပါတယ်တကယ်တော့ကိန်းဂဏန်းအနေအရလည်းမနည်းလာပါဘူးဒီမှာဆိုရင် thrombosis ကအခုဆိုရင် global problem ဖြစ်တောင်တင်စားနေကြပါပြီ၄ယောက်မှ1ယောက်ပေါ့နော်တစ်ကမ္ဘာလုံးဆိုရင်နောက်တစ်ခါသူ့ကြောင့်ရှိတဲ့အတိအပြောက်ကခေတ်စားနေတဲ့ AID ရဲ့ cancer accident တွေတက်တောင်မှများတယ်ဥရောပမှာဆိုရင်တော့မိနစ်ဝက်မှာ1ယောက်လောက်တည်ရတယ်ဆိုတဲ့ဟာတွေလည်းရှိနေပါတယ်ဒါက thrombosis ရဲ့ burden လေးကိုတင်ပြလိုတာဖြစ်ပါတယ်နောက် adjustment တစ်ခုကသွေးလွှတ်ကြောနဲ့သွေးပြန်ကြောသဘောကမတူတော့ယူဆစရာနောက် adjustment တစ်ခုပေါ့အဲ့ဒါကတော့ arterial နဲ့ venous thrombosis ခြားမှာပါအဲ့ဒါကတော့ antiplatelet နဲ့ anticoagulant စဉ်းစားရမယ်အခြေအနေလေးကိုတင်ပြလိုပါတယ်အဲ့တော့ခုနကဆရာ previous speaker တွေလည်းတင်ပြသွားသလိုပဲthrombosis က artery မှာလည်းဖြစ်နိုင်တယ် vein မှာလည်းဖြစ်နိုင်တယ်နည်းနည်းလေးကွာတာလေးတော့ရှိပါတယ်ဥပမာဆိုရင် risk factor အနေနဲ့ပြောမယ်ဆိုလို့ရှိရင် arterial thrombosis ကတော့ atheroma ဖြစ်ပြီးတော့ venous ကတော့ immobility အဓိကဖြစ်ကြတာဖြစ်ပါတယ်ဒါအပြင်နောက် pathogenesis ကိုကြည့်မယ်ဆိုလို့ရှိရင်လည်း arterial thrombosis ကတော့ဒီနေ့ endothelial damage ကစပြီးတော့ venous ကတော့ stasis နဲ့ hypercoagulability ကြောင့်ဖြစ်တာတွေ့ရပါတယ်နောက် symptoms ကိုကြည့်မယ်ဆိုလို့ရှိရင်လည်း arterial thrombosis မှာဆို sudden onset ဖြစ်လေရှိပြီးတော့ venous ကတော့ usually ကတော့ slow onset ဖြစ်လေရှိပါတယ် thrombosis ကိုပြောတာပါ thromboembolism ကိုပြောတာမဟုတ်ပါဘူးနောက်တစ်ခုကတော့ complications ပေါ့ complication ကိုကြည့်မယ်ဆိုလို့ရှိရင်လည်း arterial thrombosis ကတော့ infarction အဓိကဖြစ်တော့ venous ကတော့ embolism pulmonary embolism နဲ့ပြဿနာပေးတာများပါတယ်နောက်သူတို့ရဲ့ thrombus ရဲ့ tail လေးကိုကြည့်မယ်လို့ရှိရင်လည်း arterial မှာတော့ blood flow နဲ့နောက် blood flow စီကိုသွားတယ် blood flow ကအဝေးကိုသွားစသည်ဖြင့်ကွဲပြားတာရှိပါတယ်နောက်ဆုံး detachment ကိုကြည့်မယ်ဆိုလို့ရှိရင်လည်း arterial thrombosis ကတော့ thrombus အကုန်လုံးပြုတ်ထွက်လေးရှိပြီးတော့ venous thrombosis က tails လေးရနေထွက်လေးရှိပါတယ်အဲ့တော့ဒီအချက်တွေကိုအခြေခံပြီးတော့ကျွန်တော် treatment aspect ကိုစဉ်းစားလေးရှိပါတယ်ဒီ arterial thrombosis နဲ့ဒါတော့ venous thrombosis ရဲ့ theoretical difference လေးတွေပေါ့နော်ဒါတော့ electron microscope နဲ့ကြည့်လိုက်တဲ့အခါကျရင်လည်းဒီ arterial thrombosis က platelets များပြီးတော့သူ့ကို white clots လို့ဆိုကြပါတယ်ဒါတော့ venous thrombosis ကြတော့ fibrin တွေပိုများတယ်အထက်မှာ RBC ကိုသူကအုပ်ထားတော့ red clots လို့ဆိုလေးရှိပါတယ်ဒါပေမဲ့ဖြစ်စေတဲ့ risk factor အစ overlap ဖြစ်နေတဲ့ mechanism တစ်ခုမှလည်းအရင်ကျွန်တော်ရှင်းပြခဲ့တယ်လို့ရောထွေးနေမှာမလို့ဒီနှစ်ခုက arterial ဆိုရင်တော့ antiplatelet ပဲပေး venous ဆိုရင်တော့ anticoagulant ပဲပေးဆိုပြီးတော့ခွဲခြားလို့တော့ခက်ပါတယ်တကယ်တော့သွေးကြောပိတ်ခဲစေတဲ့အကြောင်းလွန်ခဲ့တဲ့နှစ်တရာကျော်မှာ fear ကိုပြောခဲ့တာအခုထိမှန်နေစေဖြစ်ပြီးတော့သွေးခဲပိတ်ခြင်းဟာသွေးရယ်သွေးကြောရယ်သွေးစီးမျောတာရယ်ပေါ်မူတည်တယ်ဆိုတာအခုထိမှန်နေပါတယ်ဒါပေမဲ့တကယ်တော့သွေးခဲဖြစ်သွားပြီဆိုတာကတော့ coagulation ကအဆုံးသတ်ဖြစ်တော့ဒီ stabilize clause နဲ့အဆုံးသတ်တာဖြစ်တဲ့အတွက် coagulation ကိုတားဖို့ကတော့ thrombus အားလုံးမှာအရေးပါလာပါတယ်အဲ့တော့ thrombus extension ဖြစ်ဖြစ် thrombosis ကို prevention ပဲဖြစ်ဖြစ်ဒီ stabilize clause ဟာ coagulation ကြောင့်ဖြစ်တာဖြစ်ပြီးတော့သူကမှတစ်ဆင့်ကျွန်တော်အားလုံးကြောက်ကြတဲ့ cerebrovascular disease တွေ coronary artery disease တွေ thromboembolic disease တွေရဲ့အကြောင်းရင်းပဲဖြစ်ပါတယ်ဒါကြောင့်ဒီ anticoagulants ဟာဒီ disease တွေအားလုံးမှာအရေးပါလာတာပဲဖြစ်ပါတယ်ဒါကြောင့် anticoagulation ဟာကျွန်တော်တို့အရေး medical field မှာတော့ခုနက chairperson ဆရာကြီးများပြောကြားခဲ့တယ်လို့ပဲအရေးပါလာတာပဲဖြစ်ပါတယ် anticoagulation ပြီးပြီဆိုတော့ နောက် adjustment လုပ်ဖို့လိုတာကတော့ anticoagulants တွေနဲ့ခန္ဓာကိုယ်အကြား pharmacokinetic နဲ့ pharmacodynamic နော်ဒီမှာဆေးရဲ့အစွမ်း efficacy နဲ့ဆေးရဲ့ထိရောက်မှု effectiveness နဲ့လူနာနဲ့ယောဂအပေါ်တက်ရောက်မှုကြားပေါ့နော်ဒါမှစဉ်းစားရမယ့်အခြေအနေလေးတွေကိုတင်ပြလိုပါတယ်တကယ်တော့ anticoagulants ပေါ်လာတာကတော့နှစ်100ကျော်ပါပြီသူ့အကြောင်းလဲတော်တော်လေးသိလာကြပါပြီစတွေ့တာတော့ heparin ပေါ့ဒါဆေးကြောင်းသားတီထွင်တဲ့ဆေးပေါ့နော်နောက်ကြတော့နွားတွေကမှုတဲ့စီးပွားကတ်ဆိုင်တော့ပိုတက်နေတဲ့အပင်ကြောက်တွေကျွေး sweet clover ပေါ့နော်အဲ့မှာသူနွားတွေသွေးထွက်များပြီးတေကြတာကိုလေးလာကနေစပြီးတော့ warfarin ကစတွေ့ပါတယ်အဲ့နောက်ပိုင်းမှာတော့clinical trial တွေလုပ်အနက်မရှိလို့သူ့ကိုကြွက်တက်စေးဖြစ်သုံးတယ်အဲ့ဒါကိုကိုယ်တက်တဲ့အခါမှာမတေတာကနေတဆင့်သူ့ရဲ့အာနိသင်ကိုသိပြီးတော့အမေရိကန်သမ္မတအိုင်ဇင်ဟောဝါနှလုံးသွေးကြောယောဂဖြစ်တဲ့နေရာမှာသုံးတာကနေစပါတယ်အဲ့နောက်ပိုင်းမှာ mechanism တွေလည်းသိလာပါတယ်တစ်ဖက်က heparin ရဲ့ molecular mechanism ကိုသိတဲ့နောက်ကို modify လုပ်တာတွေလည်းရှိလာပါတယ်အခုဆိုရင်တော့ဒါနှစ်တရာရှိပြီးတော့ဒီ anticoagulation ရဲ့ history ဟာရာပြည့်ကျော်ခဲ့ပါပြီအဲ့တော့ဒီမှာဆိုရင် heparin ဆိုတော့ low molecular heparin နဲ့ unfractionated heparin ကြာကွာခြားတာသိဖို့ရ mechanism ကိုအနည်းငယ်တင်ပြလိုပါတယ်ဒီ unfractionated heparin ကသူက inactive antithrombin ကိုပေါင်းပါတယ်အဲ့လိုပေါင်းပြီးတဲ့အခါမှာ active ဖြစ်သွားတဲ့ antithrombin က active factor 10 ကိုလာပေါင်းပါတယ်အဲ့လိုပေါင်းတဲ့အခါမှာ factor 10 က prothrombin ကို thrombin မပြောင်းနိုင်တော့ပါဘူးအဲ့ဒီခါကျတော့ fibrinogen ကို fibrin ဖြစ်တာကိုတားတဲ့အတွက် coagulation ကရပ်သွားပါတယ်ဒါအဲ့တော့နောက်ထပ် blood clot မဖြစ်တော့ပါဘူးနောက် unfractionated heparin က antithrombin က thrombin ကိုတားတဲ့နေရာမှာလဲကူပေးပါတယ်ဒီမှာဆိုရင် thrombin ကိုလာပေါင်းတယ်အဲ့လိုပေါင်းတဲ့အခါမှာသူကအမီးရှည်တဲ့အခါကျတော့ဒီပေါင်းတာဒီလိုမျိုးချိတ်ထားပြီးတော့သူကကြာပါတယ်ကြာခံတဲ့သဘောရှိပါတယ်အဲ့ခါကျတော့သူက factor 10 ရော thrombin ရောတားတယ်သူ့ရဲ့ action ကပို့ပြီးတော့ potent ဖြစ်ပါတယ် low molecular heparin ကြတော့သူကဒီလိုမျိုးအမီးတူနေတော့သူက factor 10 ကိုတော့ active factor 10 ကိုတော့တားတာတော့အတူတူပါပဲသူလည်း active antithrombin ဖြစ်တယ်ဒါတားတယ်အဲ့လိုပဲအလားတူပဲသူက thrombin ကိုလည်းသူတားနိုင်ပါသေးတယ်သူက thrombin တားတဲ့အခါကျတော့သူ့ရဲ့အမီးကတိုးနေတော့ thrombin ကိုကြာမချိတ်နိုင်ပါဘူးကြာမတားနိုင်တော့ခဏပဲတားတယ်အဲ့ခါကျတော့သူ့ရဲ့ thrombin ပေါ်မှာ action ကကြတော့ unfractionated heparin လောက်မကြပါဘူးကြာတော့သူကဒီ pharmacokinetic dynamic မှာကွာခြားချက်ကလေးရှိလာတာဖြစ်ပါတယ်ဒီအရပြောရင်ဒီ thrombin ပေါ်မှာ effect က minor ဖြစ်ပါတယ် ultra low molecular heparin ကတော့ပို့ပြီးတော့ minor ဖြစ်ပါတယ်ဒါကြောင့်ဒီ heparin ရဲ့ mechanism ကိုခုနက clotting pathway မှာကြည့်မယ်ဆိုလို့ရှိရင် unfractionated heparin ကကြတော့နှစ်ခုစလုံးတားတယ် low molecular heparin ကတော့ thrombin မှာနည်းတယ် ultra low molecular heparin ကတော့ factor 10 မှာပဲတားပါတယ်ဒါပေမဲ့သူ့ရဲ့ limitation တွေလည်းရှိပါသေးတယ်အရင် speaker တွေလည်းပြောပြီးသားဆိုတော့ကျွန်တော်အသေးစိတ်တော့ explore မလုပ်တော့ပါဘူးသူ့ရဲ့ anticoagulation response က variable ဖြစ်တယ်ဘာလို့လဲဆိုတော့သူက plasma protein တွေရော endothelium ကိုရော macrophage တွေရောပေါင်းလို့ပါပဲနောက်တစ်ခါသူက antibody to platelet နဲ့ platelet factor 4 နဲ့ heparin ကိုတွားပြီးတော့ antibody ဖြစ်တော့ thrombocytopenia လည်းရနိုင်ပါတယ် heparin က HIT ပေါ့နော်နောက် drug interaction တွေလည်းရှိတယ်နောက် platelet invading function ကိုပါ bleeding ရနိုင်တယ်နောက် viability ကပူဝါဖြစ်တယ်နောက်ပြီးတော့သူက prothrombin complex မှာရှိတဲ့ ferritin ကို activate မလုပ်နိုင်ဘူး thrombin ကိုမလုပ်နိုင်ဘူးအဲ့ဒါကြောင့်သူက viability ကလည်းပူပွားဖြစ်တယ်ဒါကတော့သူ့ရဲ့ limitation တွေပါဒါအပြင်အရေးကြီးဆုံးကတော့သူကတော့ oral form မဟုတ်ပါဘူးအဲ့အတွက် warfarin ပေါ့နော် warfarin ကတော့ပထမတော့ဒီသူတို့နွားပိုင်ရှင်တယောက်ကသွေးပုံကြီးကိုသူက research center ကိုယူလာတယ်အဲ့သွေးကမခဲဘူးဘာလို့လဲဆိုတော့သူကနွားတွေကစီးပွားပြက်ကန်းဖြစ်တော့ပေးရိုင်းပင်မှုတဲ့ထွက်တဲ့ပေးရိုင်းပင်မှုတက်တာတွေကိုကျွေးတယ်အဲ့မှာသူက coumarins ပါတော့သွေးမခဲပဲ minor injury လေးတွေနဲ့တည်ကြတာဖြစ်ပါတယ် University of Wisconsin ကိုလေ့လာဖို့ကူညီပြီးတော့သူက isolate လုပ်တဲ့လူကသူ့ကို coumarin ကို Wisconsin University Alumni Research Foundation ကိုထည့်ပေးလိုက်တော့ warfarin ဖြစ်သွားပါတယ်ပထမတော့သူကကြွက်သက်ဆေးပါပဲနောက်ကြမှသူကsuicide လုပ်ပြီးမတည်တဲ့အခါမှာ clinical use ဖြစ်နိုင်တာသိပြီးတော့လူမှာလေ့လာတဲ့အခါမှာကမ္ဘာမှာအသုံးများဆုံးဆေးတစ်ခုဖြစ်လာပါတယ်သူရဲ့ mechanism ကလည်းဒီ coagulation ပေါက်သွေးမှာကြည့်မယ်ဆိုလို့ရှိရင် warfarin ကဒီလိုမျိုး vitamin K dependence anticoagulant တွေကိုလာထားတာရှိပါတယ် warfarin ကလည်းလိုအပ်တာတွေကမနှဲပါဘူးတချို့ပြောလို့ရှိရင်တော့ slow onset ဖြစ်တယ်အဲ့ဒါကြောင့် heparin bridge လောက်ရတယ် slow offset ဖြစ်တယ်အဲ့ခါ post procedure မှာ complication တွေရနိုင်တယ် therapeutic window က narrow ဖြစ်တယ်အဲ့ဒါကြောင့်ခဏခဏ monitor လုပ်ရပါတယ်တခါ drug interaction တွေရှိတော့ dose ကလည်း variable ဖြစ်တာကိုတွေ့ရပါတယ်ဒါတွေရတော်ပါသေးတယ်ပြဿနာကတော့သူ့ရဲ့ hazard ကတော့ဒီ bleeding ပါပဲဒီ trial တွေတော်တော်များများမှာကြောက်ရတာတွေးထွက်တာဖြစ်နေပါတယ်ဒါကြောင့် now adjustment လိုလာတာကတော့ benefit နဲ့ risk တွေကြားမှာပဲဖြစ်ပါတယ်အဲ့ဒါကတော့ anticoagulation နဲ့ hemorrhage ကြားစဉ်းစားရမယ့်အခြေအနေကိုဆိုလိုတာပဲဖြစ်ပါတယ်ဒါကြောင့် score တွေမှာလည်းလေဖြတ်မဲ့ဘေးတာမကတွေးထရမဲ့အရေးထက်တွေးပြီးတော့ဆွဲလာကြတာတွေ့ရပါတယ်အဲ့ခါမှာဒီတွေးထတာနည်းဖို့စဉ်းစားစရာဖြစ်လာပါတွေးခဲဖြစ်ကြောင်းရှာမယ်ဆိုလို့ရှိရင်တော့အားလုံးသိတဲ့အတိုင်းပဲခုနက fear codes try မှာလည်းပြောခဲ့တဲ့အတိုင်းနဲ့တွေးကြောနဲ့တွေးစီးမျောတာပြဿနာဒါပေမဲ့အဆုံးမှာတော့ဒီ ferritin နဲ့ thrombin တို့ပါတဲ့ fibrinogen ကနေ fibrin ဖြစ်ခြင်းဆိုတဲ့အရာမှာအဆုံးသတ်တာဖြစ်ပါတယ်အဲ့ခါကျတော့ research တွေကလည်းဒီ ferritin နဲ့ thrombin ကိုဥတီတဲ့ဆေးတွေကိုဖော်ထုတ်နိုင်ဖို့စူးစမ်းခဲ့ကြပါတယ်အထူးသဖြင့်ဒီ fibrin mesh ကိုဖြတ်မဲ့ဆေးကိုဘယ်ဥစ္စာကအရေးကြီးဆုံးလဲပေါ့နော် prevent လုပ်မဲ့ဆေးကိုဆိုလိုတာဖြစ်ပါတယ်အဲ့မှာဆိုလို့ရှိရင် thrombin inhibitor တို့ ferritin inhibitor တို့ပေါ်လာကြပါတယ်အဲ့တော့ဒီ NOAC လို့ခေါ်တဲ့ new oral anticoagulant clotting pathway မှာရှိတဲ့အရေးကြီးတဲ့ ferritin ကိုလာတားတဲ့ဆေးဖြစ်တဲ့ epixifen လို့ဆေးမျိုးတွေရဲ့ thrombin ကိုတားတဲ့ဆေးမျိုးတွေကိုပေါ်ထုတ်လာကြပါတယ်သူတို့ရဲ့အားသာချက်ကတော့ single hit နဲ့ direct hit ပဲဖြစ်ပါတယ်လိုတဲ့နေရာကိုပဲရွေးပြီးတော့တိုက်တာဖြစ်ပါတယ်သူတို့ရဲ့ advantage တွေကတော့အရင် speaker တွေလည်းတင်ပြခဲ့တယ်လို့ပါပဲတိတာထင်ရှားအကျိုးတွေများပါတယ် onset ကမြန်တယ် dosing ကလည်း fix ဖြစ်တယ်အစာနဲ့ interaction ကလည်းမရှိဘူး drug interaction လည်းနည်းတယ် monitoration မလိုဘူးလွယ်နဲ့လည်း anticoagulant effect ကိုရက်လို့ရတယ်ဆိုတာရှိပါတယ်တကယ်တော့ဥမာ AF ကိုနမူနာထားပြောရမယ်ဆိုရင်အရင် speaker လည်းပြောခဲ့ပြီးသားဖြစ်ပါတယ်လက်တွေ့မှာလည်းအထောက်အထားအမြောက်အများရှိတဲ့အကြောင်းပေါ့နော်ဒီမှာဆိုလို့ရှိရင် warfarin နဲ့ဆိုင်တဲ့ trial 6ခုရှိပါတယ်ကိုရှိဒီအဲ့6လားလူပဲဒါက new oral anticoagulant အနေနဲ့ဆိုင်တဲ့ trial တွေပါကျွန်တော်အဓိကထောက်ပြလိုတဲ့ချက်က warfarin နဲ့ဆိုင်တဲ့ trial တွေမှာရှိတဲ့ participant 3000လောက်ရှိတဲ့အချိန်မှာ NOAC နဲ့ဆိုင်တဲ့ trial တွေမှာ9000ကျော်လောက်ထားတာဖြစ်ပါတယ်ဒီနည်းအားပြောရင်အထောက်အထားကအမြောက်အများပဲခိုင်လုံလှပါတယ်ဆိုတာလေးပြောချင်တာဖြစ်ပါတယ် warfarin မှာအထောက်အထားအရသူတို့ခုနပြောခဲ့တာပါတယ်အဲ့မှာနောက်တစ်ခုက secondary outcome ဒီ sorry ပထမပြခဲ့တာဒီ primary outcome မှာဆိုရင်ဒီ rivaroxaban once daily oral direct ferritin inhibition compared with vitamin K antagonism for prevention of stroke and embolism trial ပေါ့နော်ဒီ rocket AF အပေါင်း rely စသဖြင့် trial တွေအားလုံးမှာ ဘယ်ဘက်ကို favor ဖြစ်လဲဆိုတော့ NOAC ကို favor ဖြစ်ပါတယ်။ဒါ primary outcome ပေါ့ secondary မှာတော့ safety outcome မှာဆိုလဲတူးကြောက်ရတဲ့ ICH မှာဆိုရင်တော့ဒီ NOAC တွေကပို့ပြီးတော့ preferable ဖြစ်တာကိုတွေ့ရပါတယ်။လားတူပဲ BTE မှာဆိုလဲ primary outcome မှာ warfarin နဲ့ inferior မဖြစ်ဘူး။ နောက် safety မှာဆိုရင်လဲသူတို့က superior ဖြစ်တယ်စသဖြင့်အထောက်အထားတွေတော့ရှိခဲ့ပြီးဖြစ်ပါတယ်။လားတူပဲဒီ orthopedics မှာဆိုရင်လဲ less thrombosis more bleeding ဆိုတော့သူက orthopedic BTE prophylaxis မှာပို့ပြီးတော့ establish ဖြစ်နေပါတယ်။ဒါကြောင့်ဒီ new oral anticoagulant တွေအကြောင်းပြောရရင် trans က less bleeding ဖြစ်တယ်။ ICH ကိုတော်ဝယ်နီးပါးချနိုင်တယ်။ဒါပေမဲ့ GI bleeding ကိုတော့မချနိုင်ပါဘူး။နောက် INR က control မကောင်းတဲ့အခြေအနေပါတော့မှသူတို့က less bleeding ဖြစ်တာကိုတွေ့ရပါတယ်။အဲ့တော့ကျွန်တော်နောက်ဆုံး final arts of adjustment အနေနဲ့ကတော့ value နဲ့ cost အကြောင်းလေးပြောလိုပါတယ်။တန်ဖိုးနဲ့ဈေးပေါ့နော်။တန်ဖိုးနဲ့ဈေးဟာပြောင်းပြန်အချိုးကျတာဆိုပြီးနဲ့ဒီနေ့ပြောရင်ဈေးကြီးလာရင်တော့တန်ဖိုးကသူရရတဲ့အကျိုးကနည်းတယ်လို့တချို့ကဆိုနိုင်ပါတယ်။ဒါပေမဲ့ health outcome ကိုထည့်စဉ်းစားရင်တော့သူက health outcome များလေတန်ဖိုးကများလေပေါ့နော်။အဲ့ဒါဆိုရင်တော့ cost များတာကလည်းပြဿနာမဟုတ်တော့ဘူးနော်။ဒါကြောင့်ဒီဈေးသာစဉ်းစားအကျိုးများတာတွေးမထားရင်တော့ကျွန်တော်လူနာရဲ့ health benefit ကိုထည့်မတွေးလို့ဖြစ်နိုင်တဲ့အတွက်ကျွန်တော်တို့ကစဉ်းစားတဲ့အခါမှာ value နဲ့ cost ကို outcome ကိုပါထည့်စဉ်းစားဖို့လိုတဲ့အကြောင်းတင်ပြရင်းနဲ့ကျွန်တော်တင်ပြမှုအဆုံးသတ်ခွင့်ပြုပါခင်ဗျာကျေးဇူးပါတယ်
တွေ့သွားသောအကြောင်းအရာများနဲ့ပတ်သက်ပြီးမိကွန်းများကို chairperson နှင့် speaker များမှပြန်လည်ဖြေကြားမှာဖြစ်တဲ့အတွက်မိကွန်းများမေးမြန်းနိုင်ပါပြီရှင်မိကွန်းလေးများဖြေကြားပေးဖို့အတွက် Symposium chairperson နှင့် speaker များနေရာယူပေးပါရန်မေတ္တာရက်ခံအပ်ပါတယ်ရှင်
where we have very good speakers, 3 speakers, who has talked about the various aspects of anticoagulation, new anticoagulant, oral anticoagulant therapy, very comprehensively and very informatively. However, there can be some points for clarification or some points for questions. So this is now time for questions and answers. We are very pleased to have speakers here on the stage as well as our renowned chairperson here. The time is for the question and answers. So all the audience, you can start raising the questions to our honorable speakers and chairperson as well. I am an endocrinologist. I'm privileged to have 2 renowned chairpersons, cardiologists as well as hematologists. So those questions, I would direct them to them because the topic is mainly concerned. In addition to that, we are privileged to have a renowned, cardiologist here from India and also a general physician. So we will direct the questions. To start the ball rolling, here we have some questions. I think it is asked by online. The first question is, if the patients get ischemic stroke while taking warfarin or NOAC, respectively, will they be continued or stopped? Actually, the various speakers will talk about it, but however, it is us here and who will break the stone, who will break the ice, who will answer. If the patient gets ischemic stroke while taking warfarin or NOAC, will they be continued or stopped?
Yeah, very, very important question. So because I have a patient who is already on anticoagulation, has come with a stroke. It could be a TIA or a ischemic infarct. So the challenge at this point is, if I continue, will it become hemorrhagic? Number one. Number two, do we have to treat effectively the stroke? These two questions come in one. So one side, whether I can stop it, otherwise, how to give an effective therapy when there is an ischemic stroke. Okay. So the common thing is we look at the size of the infarct and the level of the neurological impairment. Is it my small TIA, sometimes within 24 to 48 hours? If it is a larger stroke, gross disability, we may have to delay reinstitution of the NOACs for several days. Typically, a very severe stroke, sometimes we delay it up to 28 days. In this situation, we look at few things. One is the imaging data, neurological status of the patient, number one. Number two is, what do you do when you are stopping? Naturally, you are going to move into the other therapy like parenteral anticoagulation and thrombolytic therapy or a catheter-based therapy. So this is a paramount important. So you can stop the anticoagulation, NOACs or warfarin, depending on the severity for few days to few weeks. Instead, the recommended therapy like catheter-based thrombolysis or catheter-based intervention or thrombolytic therapy. Important thing is estimate the level of the disability. One point of caution is, at this point, will it become a hemorrhagic transformation or can I go with thrombolysis? There comes the antidotes. So I have a patient with a large neurological stroke. I want to go for a thrombolytic therapy. Sometimes I may have to reverse the anticoagulation. There the question comes, how early he has taken, that is before the onset of the stroke. Was it taken 12 hours before or 24 hours before? The level of inhibition. You can do immune blood test if the lab is available. Sometimes if the problem is significant, you can reverse it. Further, there are two reversal agents. For dabigatran, we have idarosizumab, a monoclonal antibody. Or for other tenin inhibitors like edoxaban or rivaroxaban, apixaban, we do have antaxolate alpha. The doses are well defined now, we can use it. The problem what we face in the situation, availability of these things. Idarosizumab is praxibind by name, it's freely available in India. Antaxolate alpha is available in Europe. I don't know about this country, available in US also. So this is the thing. So look at, assess him, reverse him, give him thrombolytic therapy, withhold the anticoagulant depending on the impairment and restart within the short frame of time depending on the level of impairment.
Thank you. Thank you, Professor Muralidharan. Sorry for my pronunciation. Well, it's a good question, although it's being talked by Professor Damien. It is asked that what are the biomarkers for RV dysfunction and superficial VD? Do they need anticoagulant and which drugs?
First question.
First question, what are the biomarkers of the RV dysfunction?
In the guideline for the assessment of the RV dysfunction in the patient with the PE, we should do the two things. One is the first thoracic echo and biomarker is that means troponin, whether I or T. That's all. No other biomarkers.
Yeah,
Second
and
question.
The second question is the superficial VD. Do they need anticoagulants?
In the patient with the superficial venous thrombosis, superficial venous thrombosis are very rare to get the embolism. So in the management of the superficial thrombosis, there is just a symptomatic therapy is a mainstay of treatment. No need to give the anticoagulant therapy unless it extends to the deep vein thrombosis and the prone to get the embolism. Yeah. I think those questions come from the physician.
နည်းနည်းလေး egg လုပ်ချင်လို့ပါ superficial venous thrombosis က ဒီ spontaneous superficial venous thrombosis ကစောစောကကိုသိမြင့်ပြောသလိုပဲကုရမလားမကုရမလားပေါ့ဆိုတော့ဒီ guideline တွေအားလုံးကကုပါလဲပြောတယ်ကြည့်ပါလဲပြောတယ်ပေါ့နော်ဆိုတော့ဒါတကယ်တမ်းတော့စောစောက superficial venous thrombosis လို့ပြောပေမဲ့အဲ့ဒီ thrombosis က proximal vein နဲ့နီးတဲ့ဟာအပေါ်ပေါ့အထူးသဖြင့်တော့ proximal junction လို့သူတို့ခေါ်တာပေါ့နော် venous vein နဲ့ junction ဖြစ်တယ် thrombosis က length ကလည်းကြီးမယ်ဆိုတော့ underlying risk factor တွေလည်းရှိတယ်ဆိုလို့ရှိရင်တော့ကုခိုင်းတယ် superficial venous thrombosis ကိုလည်း ignore မလုပ်ပါနဲ့လို့ပြောတယ်ဘာဖြစ်လို့ဆိုတော့ဟို superficially ပဲဘာမှမဖြစ်ပါဘူးဆိုပေမဲ့လည်း superficial venous thrombosis တွေလည်း embolism ရနိုင်တယ်ပေါ့ကုတဲ့အခါမှာတော့ဘယ်လိုကုမလဲဆိုတော့ DVT လို့ကျွန်တော်တို့ကအပြည့်အဝကုရမလားဆိုတော့သူတို့ပေးတဲ့ dose က very low dosage ပဲ Fondaparinol ဆိုရင်လည်း 2.5 mg OD Rivaroxaban ဆိုလည်း10 mg OD ပဲဆိုတော့ acute VD ရဲ့ treatment dose နဲ့မတူဘူး low dose ရက်ကောဘယ်ရဲ့ပေးမလဲ3လပေးရမှာလား6လပေးရမှာလားသူ superficial venous thrombosis အတွက်ကတော့45ရက်ပဲဒါသူတို့ duration က very short ဆရာတို့ကုလို့ရတယ် low dose anticoagulant short duration ပေါ့ကြွေကိုရဲ့လူနာသည် superficial ဖြစ်တော်လဲပဲ length ကလည်းကြီးနေတယ်ရောင်လဲရောင်နေနာလဲနာတယ် proximal vein အပေါ်ပဲလဲနီးတယ်ဆိုရင်တော့ကုလို့ရပါတယ် low dose short duration
So we got the point. No, Professor Tununji has made a point very clear. Although this is superficial, it depends on the length of the thrombus and whether the patient is having a symptoms or not. So we should consider these things, take into consideration for the treatment. And treatment is just 45 days low dose. So I think you've got the answer. Thank you, Professor Tununji. And the next question is, if I have to read it by verbatim, how to differentiate different diagnosis of DVT. I think how to get a diagnosis in the setting of poor lab setting, in the resource limiting area. One doctor says giving anticoagulation in DVT is just preventing extension of clot, but to disappear clot, so embolism chance is still there. Is it right? To clot so in the setting of the poor resources to diagnose the DVT, well, how can we confirm the DVT? That's the first question. And second part is anticoagulant for the prevention of extension. And my previous solution is clock is still there. Is there any chance of embolism? She did laugh. Very good question.
Very good. Very difficult to answer.
It is too good.
It's too good for me. So, ဟုတ်ပါတယ်ကျွန်တော်ပြောခဲ့တဲ့ထဲမှာတော့ဟို PE ကိုတော့ focus လုပ်ပြီးပြောသွားမယ် DVT ကိုနည်းနည်းဖော့ပြောသွားတာ DVT ကတော့ first thing ကတော့ suspicious ပေါ့နော် high index of suspicious ပေါ့အဲ့ဒါကတော့ဗာလဲဆိုတော့ any leg swelling ပေါ့အဓိကကတော့ leg swelling ဘာလို့ provoke ပဲဖြစ်ဖြစ် unprovoke ပဲဖြစ်ပေါ့ any leg swelling unilateral leg swelling ဆိုလို့ရှိရင်တော့ပို့ပြီးတော့ suspicious ဖြစ်တယ်ပေါ့ definitive diagnosis ကတော့သူတို့ကလည်းတကယ်တော့ဟိုနည်းနည်းပဲ Doppler နဲ့ပဲလုပ်ခိုင်းပါတယ်ဟို venogram တွေဘာတွေတော့ guideline ကတော့နောက်ပိုင်းမှာ special circumstances မဟုတ်လို့ရှိရင်အဲ့ခက်ရခက်စစ်ဟာတွေကိုလုပ်ဖို့တိတ်ပြီးတော့သူတို့ကဟိုမပြောဘူးပေါ့နော်လွယ်လွယ်ကူပဲ pulmonary embolism နဲ့ပဲ CTPA နဲ့ပဲလုပ်ခိုင်းတယ် venous ဆိုရင်လည်း Doppler နဲ့ပဲလုပ်ခိုင်းတယ်ကျန်တဲ့ဟို test တွေကရှိတယ်တိုးတော်လည်းအရင်မလုပ်ဘူးတကယ်လို့ तू ကဘာလဲဆိုရင်တော့ဟိုစကတည်းကဟိုသူမှာ provoke factor တွေရှိတယ်ဆိုတော့ Doppler တန်းလုပ်လိုက်ပေါ့ provoke factor တွေလည်းမရှိဘူးတန်တရားလည်းဟိုတူတူလို့မတူတူလို့ဆိုရင်တော့ဒီတိုင်းမှာလေးစစ်ပြီးတော့မှပဲတက်တယ်ဆိုရင်ဆက်ပြီးတော့ Doppler ဆက်သွားလို့လည်းရပါတယ်ဒါကတော့ diagnosis ပေါ့နော်အဲ့တော့အဲ့ဒီခါမှာခုန second question ကဟို anti thrombotic therapy ပေးတာလားသူမေးသွားတဲ့ပုံစံအော်ဒီသူကတော့ဟိုဘယ်လိုလဲဆိုတော့တကယ်တော့ဟုတ်ပါတယ်ဒီ DVT ရော PE ရောမှာကျွန်တော်တို့က management ထဲမှာအမြဲတမ်းအုံနောက်စားစရာကခါတိုင်းတခြားဥမာ stroke တို့ myocardial infarct တို့ဆိုကျွန်တော်တို့ thrombolysis ကိုတန်းလုပ်ချင်တာပေါ့ဒီဥစ္စာတန်းလုပ်လိုက်ရင် thrombosis ပြန် thrombolysis လုပ်လိုက်လို့ရှိရင် reperfusion therapy ဖြစ်သွားမယ်ပေါ့အဲ့ဒါဘာလို့မလုပ်လဲလို့လိုက်ရှာဖတ်ကြည့်တဲ့အခါကျတော့သူတို့ကလုပ်ကြည့်တယ်လုပ်ကြည့်တဲ့အခါမှာဘာဖြစ်လဲဆိုတော့ခုနဆရာကိုအောင်ကျော်သူဆွေးနွေးသွားတယ်လို့ပဲ benefit နဲ့ risk ပေါ့ thrombolysis လုပ်လိုက်တဲ့ဟာတွေရဲ့ဟာမှာရတဲ့အခါမှာ risk ကပိုများနေတယ် hemorrhagic transformation တွေအရန်များတယ်များတဲ့အခါနောက်ဆုံးကျတော့ benefit ကလည်းအရန်မသေးကွယ်ဘူးအဲ့တော့အခုနောက်ဆုံးတော့ပြီးခဲ့တဲ့ latest guideline 3 ခုရှိတာပေါ့တစ်ခုကတော့ American Thoracic Society guideline ရယ် American Society of Hematology ရယ် ESC ရယ်အကုန်လုံးကတညီတညွတ်တည်းပြောတယ် life threatening PE or limb threatening VTE ပေါ့DVD ပေါ့အဲ့ဒီဟာမဟုတ်လို့ရှိရင်တော့ anti thrombotic therapy ပဲပေးပါ thrombolysis therapy ဒီမပေးပါနဲ့ unless ပေးထားရတဲ့ progression ဖြစ်လာတယ်ဆိုလို့ရှိရင်တော့ life saving or limb saving အနေနဲ့အဲ့ကြလို့ရှိရင်တော့ thrombolysis reperfusion therapy တို့သူတို့ပြောတာပေါ့လေ reperfusion မှာ mainly တော့ thrombolysis therapy ပေးမယ် thrombolysis therapy ကို contra indication ဖြစ်လို့ရှိရင်တော့ surgical embolectomy လုပ်မယ်ပေါ့အဲ့လိုပဲညွှန်းပါတယ်ဟိုဟာကြီးကကြံနေလားဆိုတော့ကျွန်တော်တင်တဲ့ anti thrombotic therapy ကပေးတာရက်ပိုင်းမဟုတ်ဘူးရက်အကြာကြီးပေးရတာအကြာကြီးပေးတော့တဘာဝကသူကပြန်ကုသွားမယ်ထင်ပါတယ်ကျန်တဲ့အပိုင်းကတော့ကျန်တဲ့ဟို thrombus ကတော့ကျွန်တော်အဲ့ဒါတော့ဆရာကြီးဦးထုံးလို့ငိမ့်ရှင်းရမယ်တင်တယ်
မှန်တယ်ကိုသိမြင်ပြောတာဒီကျွန်တော်တို့ anticoagulant therapy ပေးတဲ့ရည်ရွယ်ချက်က to extension ကိုတားဖို့ပဲလေဒီရှိပြီးသား thrombosis က thrombolytic therapy ပေးမှပျောက်မှာဒီတိုင်းကတော့ရှိနေမှာပဲပေးတယ်ဆိုတာကဒီ extension ကိုတားတာဒါတော့ရှိနေတဲ့ thrombus ကပျောက်မလာလို့မေးပျောက်တာပေါ့ခန္ဓာကိုယ်ရဲ့ fibrinolytic system ကပြန်ပြီးတော့သူ့ကိုလုံနေမှာပဲဒါပေမဲ့ဘယ်လောက်ကြာမလဲမေးရင်တော့ဒီ thrombosis တစ်ခု thrombolysis နဲ့ resolve ပြန်ဖြစ်သွားဖို့သူတို့နှစ်ပတ်ကနေတစ်လအထိကြာတယ်အဲ့တော့အနည်းဆုံးတစ်လပေါ့အဲ့တော့အဲ့ဒါကျွန်တော်ကတော့အမြဲတမ်းတစ်လပဲပြောပါတယ်အဲ့တော့ဒီ thrombosis ဒီတစ်ခု resolve ပြန်ဖြစ်သွားဖို့ကတစ်လကြာတယ်ဆိုတော့ဒီတစ်လမှာဆရာတို့က anticoagulation ပေးတာကဘာယူရချက်လဲ embolism ကိုတားခြင်းလို့ရည်ရွယ်ချက်နောက်တစ်ခုကတော့ thrombosis extension ကိုတားတဲ့ရည်ရွယ်ချက်နဲ့ပဲပေးတာဒီရှိပြီးသား thrombosis ကြီးကပျောက်မသွားဘူးရှိနေမယ်သူကလည်းသူပြန်ပြောမယ်ကိုဟိုကပြောတယ်လို့ကိုသိမြင့်ပြောတယ်လို့ကိုခန္ဓာကိုယ်ကတော့ဒီ thrombosis ကြီးကိုဒီတိုင်းထားမှာမဟုတ်ဘူးပြန်ခြေနေမှာပဲခြေတဲ့ process ကချက်ချင်းမရဘူးကြာတယ်အဲ့တော့တစ်လကြာတယ်တစ်လကြာတော့ဆရာတို့ကအဲ့ဒီအချိန်တစ်ခုကိုစောင့်ရမယ်စောင့်ပြီးရင်အဲ့ဒီ thrombosis ကပျောက်သွားမလားမေးရင်တော့ပြန်ပျောက်ပါတယ်ဒါပေမဲ့ residual ဆိုတဲ့စကားလုံးရှိတယ် residual ကဘာလဲပြောတာလဲဆိုတော့သူတို့ကတချို့ thrombosis တွေက vein ထဲမှာရှိနေရအနေကတ်နေပြီးတော့အပေါ်မှာအဲ့ဒီ thrombus အပေါ်မှာ endothelium ကပြန်အုပ်သွားတယ်အုပ်သွားတော့ atherosclerosis တွေမှာဖြစ်တဲ့တူပဲ plug လို့သူကဖြစ်သွားတယ် vein ထဲမှာပေါ့နော်အဲ့ဒါကိုသူတို့က stable thrombosis လို့သုံးတယ်တခါတလေပြန်ပြီးဆရာတို့ ultrasound လုပ်ရင် residual ကျန်တယ် recanalization ပြန်ရနေပြီဒါပေမဲ့အထဲမှာကျန်နေတယ်ဆရာတို့သုံးတယ် chronic DVT တကယ်တမ်းတော့အဲ့ဒီစကလုံးကတိတ်တော့မရှိဘူးအဲ့တော့ဒါပေမဲ့ residual thrombosis ကျန်နေတယ်အဲ့ဒီသူတို့တွေကို anticoagulant တင်မလားမတင်မလားဒါအခုထိတော့ controversial အများစုကတော့မလိုလို့ပြောတယ်အဲ့တော့ stable plug ဆိုရင်ပြုတ်ထွက်เสีย chance မရှိတော့ဘူးသူ့အပေါ်မှာ endothelialization အဲ့ဒါကြီးကတော့ ultrasound expert တွေကသိတယ်လို့ပြောတယ်ကိုသိမ့်လိုက်ဘူးဆိုတာကျွန်တော်တို့မြန်မာကပဲဗနိုင်း hematologist ပေါ် professor ဒီဟိုမှာဗာလဲ MD Anderson Center မှာဆိုတော့ကျွန်တော်တို့ discuss လုပ်ဖူးတယ်အဲ့တော့ဒီ plug တွေကိုကုမလားမကုလားဆရာတို့ chronic DVT တွေကို anticoagulant အကြာကြီးဆက်တိုက်မလားမတိုက်မလား provoke DVT တွေကကိုသိမြင့်ပြောသလိုပဲ3လ6လတိတ် risk များရင်တစ်နှစ်ပြီးရင်ရက်လို့ရတယ် unprovoke တစ်လုံးပဲဒါပေမဲ့အဲ့တော့ဒီ chronic DVT ဆိုတဲ့ terms ကတကယ်တမ်းတော့လည်းမရှိဘူး residual thrombosis ကျန်ခဲ့တဲ့ဟာဒီသူကလည်းသူ stable plug ဖြစ်သွားရင်မလိုဘူးလို့သူကပြောတယ်ပြုတ်ထွက်စရာအကြောင်းလည်းမရှိဘူးလို့ပြောတယ်ဆိုတော့ဒီဟာလေးကဆရာတို့ရှိပြီးသား stabilize thrombosis ဒီခန္ဓာကိုယ်ကသူ့ဘာနဲ့သူဖြောပါတယ်ပေါ့နော်
အဲ့တော့ thank you ဆရာဒါပေမဲ့common finding common practice I noticed in the clinical practice so that the chronic issues some of the thrombosis become re-endothelialized the lumina DVD is still there thrombus is still there but the canalization but the common parameter we use in clinic is the D-dimer nowadays we found some patients that recanalized of there's some residual thrombus there, but D-dimer is persistently high in there. That kind of patient, just because D-dimer is high, shall we carry on? Shall we continue with the anticoagulant, or can we just leave it and just monitor?
Any problem, Ale? Oh, D-dimer, the causes of increased D-dimer, a lot of causes,
Yeah.
So not only DVT. DIC မှာလည်းတက်တယ် pregnancy မှာလည်းတက်တယ် liver failure မှာလည်းတက်တယ် any chronic or acute medically ill patient တွေမှာလည်းတက်တယ်အခုကဆရာတို့ဒါကြောင့်လည်းအခုကတော့ medical ill patient hospitalized လုပ်ပြီးဆိုရင်အခု thromboprophylaxis ကကမ္ဘာပေါ်မှာခက်စားလာတာပေါ့နော်ဆရာတို့ဖြစ်မှကုတာတဲ့ဆိုင်မဖြစ်ခင်ကြိုပြီးတားကြပါဒါပေမဲ့ underutilized ဖြစ်နေတယ်လို့ပြောတယ်ဆိုတော့ question မှာ persistent ဒီတိုင်းမှာအဲ့တော့တစ်ခေါက်ထဲတော့မရဘူး serial ဒီတိုင်းမှာလိုမယ်ပေါ့အဲ့တော့တစ်ခေါက်ထဲမှာဒီတိုင်းမှာ level ဒီပထမစစ်ထားတာ1000နောက်တော့8000 5000 something ပေါ့နော်တဖြည်းဖြည်းချင်းကျသွားတယ်ဆိုရင်တော့ no problem ဒီတိုင်းမှာ only နဲ့တော့ DVT ကိုကုလို့မရပါဘူးလို့သူတို့ကပြောပါတယ်ဘာလို့ဆိုတော့ဒီတိုင်းမှာဒီ value ဒီ for exclusion of the DVT အတွက်ပဲအသုံးကျပါတယ်တဲ့ for confirmation of DVT အတွက်ဒီတိုင်းမှာဒီအသုံးမကျပါဘူးတဲ့သူက negative predictive value လို့ကျွန်တော်တို့သုံးတယ်ဒီတိုင်းမှာများနေရင်တော့ဒါရှိနိုင်တယ်ဒါပေမဲ့ဟုတ်ရှိချင်မှရှိမယ်တဲ့ဒီတိုင်းမှာ normal ဆိုရင်တော့ you can exclude DVT လို့သူက negative predictive value ကပိုကောင်းတယ် for exclusion အတွက် for diagnosis not for confirmation for DVT confirmation for DVT ကတော့ဆရာတို့ပြောသလို ultrasound နဲ့ပဲရမယ် or something ပေါ့နော်ဒီ PTCA တို့တည်းမှာရမယ်ဆိုတော့ဆရာဦးသိဆိုတဲ့ question လိုပဲ residual DVT ကျန်နေတယ်ဒီတိုင်းမှာ level က high ဆိုရင်တော့တစ်ခေါက်ထင်းနဲ့တော့ကျွန်တော်ဘာလို့အဖြစ်မပေးဘူးကိုဗစ်ကာလမှာဒီတိုင်းမှာဒီဆရာတို့အကုန်လုံးဖောက်လိုက်ကြတယ်နယ်တွေမှာလည်းအကုန်ရကြတယ်မှန်တာတွေလည်းရှိတယ်မမှန်တာတွေလည်းရှိတယ်အဲ့တော့ဒီတိုင်းမှာဒီရဲ့ essay ရလည်းပဲ very sensitive ဆိုတော့ဒီတစ်ခုတည်းနဲ့တော့ဆရာတို့ rely မလုပ်ပါနဲ့ဒီတိုင်းမှာ persistent ဖြစ်တည်တိုင်အောင် anticoagulant ကိုတန်းပြီးတင်ဖို့တော့မလိုတော့ဘူးလို့ကျွန်တော်တို့ကအမြဲတမ်းပြောပါတယ်ဒီတိုင်းမှာတစ်ခုတည်းနဲ့ဆရာတို့မဆုံးဖြတ်ပါနဲ့ other factors တွေကိုလည်းကြည့်ပါအောင်ပေါ့နော်တဖြည်းဖြည်းချင်းပြန်ကြရင်ကြသွားလိမ့်မယ်ဒီတိုင်းမှာတက်တိုင်း liver function ဖောက်ပါဒီတိုင်းမှာတက်တိုင်းအမျိုးသမီးတွေဆိုလဲ something pregnancy တို့မဟုတ် other acute medical illness ရှိရင်ခဏလေးစောင့်လိုက်ပါအဲ့ဒါတွေ sepsis even sepsis တောင်မှဒီတိုင်းမှာတက်တယ်အဲ့တော့ပြန်ကျသွားရင်ဒီတိုင်းမှာပြန်ကျသွားလိမ့်မယ်ပြန်ကျသွားရင်ရသွားမှာပါ
Yeah, thank you. Very clear. But we are privileged by having our international speaker, Professor Murali Dharan. So can I know your opinion on high D-dimer during the COVID period? You know, because here, even the family practitioners, they check DMR and they are very readily give enoxaparin very readily in their practice. So what is the situation in India and how would you advise us?
Yeah.
If the person have raised D-dimer, but no signs of any signs of thromboembolism, how would you advise us?
Yes, sir. It's a perplexing situation. Like when we were stuck with the COVID pandemic, we did see several problems apart from acute worsening, respiratory depression, type 2 respiratory failure, sepsis. We saw an increase in thrombotic events. When, as you rightly said, there are several patients did not have any other typical feature of acute coronary syndrome or acute PE or DVT. I mean, but still the D-dimers were high. So it was becoming common practice for us to institute oral anticoagulation in them. One drug we commonly used was initially rivaroxaban. Second thing was apixaban. As you know that everything was being tried at the time rather than looking for RCT or a randomized control trial data. So we want to do the best for the patient. So any sick patient with elevated D-dimer, we were starting them on oral anticoagulation for a period of 3 to 6 months. We are watching it. Is it been evidence-proved drug? No. Other group patients were very sick in the hospital. Some of the patients who survived after several days of ventilator, hemodynamic support, they were summarily on anticoagulation. Parenteral, we moved to oral anticoagulation. So in COVID, the sicker patients, in patients who had elevated D-dimer, even the absence of any obvious thrombotic events, we were instituting them on oral anticoagulation. Drugs, 2 drugs we commonly used were rivaroxaban and apixaban. And some of the, I mean, may not be statistically significant, but there were increase in the incidence of coronary events also. Like the initial report by Bangalore et al. From New York, that there were several patients who had acute myocardial infarction, coronaries were normal. All typical for acute MI. When they did a coronary angiogram was normal, we started using the term with exacerbation of coronary artery disease to acute coronary syndrome due to pre-existing CAD or de novo MI also. So to put a nutshell, COVID was a prothrombotic condition. And when there's a risk, we gave anticoagulants.
Thank you. During the COVID, we noticed overuse of 3 medical products. First is anticoagulant. Very rarely give enoxaparin at the family practitioner. Second is antibiotic. Even with the rise of temperature, they give a very high flow, imipenem or meropenem, even at the family patient. And even with the rise of temperature, they readily give paracetamol and NSAID very common. So these are the common practice. I would say this is rather overuse. So these are the noticing. Professor Mr. Would you like to add something?
No, I would like to ask a question.
Yes, please. Please.
The first question is our professor. As we already know, warfarin is indicated for severe mitral stenosis, prosthetic half-up. But I have come across some patients. They come back from Thailand or Singapore. So I believe they are doing their guideline practice. But some people with the prosthetic, they came back with the instead of warfarin on the NOAC. So can you share your opinion and any data for that?
So I'll rephrase the question. So question is prosthetic metallic valves and use of NOACs instead of warfarin. As per the data, that's where the problem, sir. As per all the trials, presence of a prosthetic valve, particularly a mechanical valve, we have no guideline, no clear data to support NOACs. We have to use warfarin only, sir. The exceptions are patients who have a bioprosthetic valve. So a lot of my patients today who have a bioprosthetic valve, not only in aortic position, but also in mitral position, after 3 months of a warfarin therapy, we switch over to NOACs. Very convenient to give. But present mechanical valves, we are looking for data. As you rightly said, some of Singapore, there was an observational registry came from South Korea also, in a large number of patients where they could give when there was some problem of giving warfarin. Instead of warfarin, they tried, they have shown similar reports. So even current guideline, European guideline and all, they do recommend you can choose. Suppose you are left with a patient where warfarin could not be given for some reason. As an alternative, inferior alternative, you can try NOACs, but we need more data, sir. We need a good randomized trial. I don't think it is going to be there in the near future, but once it comes, we'll try it.
Now, one more question, maybe to my chairperson or speaker. I also come across with the atrial fibrillation patient need the anticoagulant therapy. They have a chronic liver disease. So chronic liver disease has a bleeding problem. So how do which one is the best for the chronic liver disease, AF, and how do we monitor? Please.
Yeah. In connection to that question, also there's a question from the audience that in case of cirrhosis of the liver with venous thromboembolism, he said, June, how to adapt, how to adjust in thrombocytosis stage, thrombocytopenia in thrombocytopenic stage. Yeah. Professor
Kondu Jala.
Kondu, do you hear my question?
Okay, what's your
opinion? Because you are
AF ne liver disease, liver impairment, anticoagulant go choose look so in a very lady you.
Okay, what's your idea? Miaro, Gonaka, Disney dog, the Lua, do a liver function impairment, blouty so neatly. Now, the general payment anticoagulation, yana benefits car blouty, Yamale, Sura, will adjust lower melu, Rogeno, Chilu Varecamia. This is a girl, CIE, Chimene to Varecamia, Jizito.
AF ka sodoan siaro aloneti bare AF ma anticoagulant temea 2 assessment ni shibira no AF ne VTE risk ka chest blow chest go blow blah so adi ma high risk so yin temba low risk so yin banyaအခုကတော့ဆရာတို့ဒီ statement ပေါင်းပြလိုက်တာက AF plus ဆိုတော့ AF နဲ့ VTE risk ကရှိပြီးသားเนาะဆရာတို့ chest score လောက်ကိုလောက်ရပါမယ် AF မှာ anticoagulant တင်မယ်ဆိုရင်အဲ့ဒါ plus အခုက liver impairment ဆိုတော့ကိုအောင်သူဖြည့်တယ်လို့ပဲ liver cirrhosis of liver or နောက်တစ်ခုက acute hepatitis နောက်တစ်ခုကတော့ liver enzyme တွေဘယ်လောက်တွေတက်နေတယ်လဲ plus နောက်တစ်ခုကတော့ PTAPTT ဘယ်လောက် coagulopathy liver coagulopathy ဘယ်လောက်ရှိနေတယ်လဲ plus thrombocytopenia ပေါ့ဆရာတို့ liver case မှာဆိုလို့ရှိရင်သူတို့ anticoagulant တင်မဲ့ကိစ္စတွေမှာ thrombocytopenia နဲ့ပေါင်းလာပြီဆိုလို့ရှိရင်ဘယ်လို anticoagulant တွေသုံးမလဲပေါ့တင်မလဲပေါ့အဲ့တော့ the same ပဲဆိုတော့ဒီ warfarin သုံးမလားဒီ NOAC သုံးမလားမှာ liver case တွေအားလုံးကဆရာတို့သိတဲ့အတိုင်း PT တွေ prolong ဖြစ်နေတတ်တယ်တခါတလေဆရာတို့ warfarin မှမစားသေးဘူး PT က already prolong အဲ့တော့အဲ့လို case တွေဆိုရင်ဆရာတို့ warfarin တင်ပြီးဘယ်လိုလုပ် INR adjust လုပ်မလဲပေါ့ဆိုတော့ဒါကခက်လာတယ်ခက်လာလို့လဲဒါကြောင့်လဲ warfarin ရဲ့ limitation တွေကရှိလာတာပါအဲ့လို problem တွေရှိလာလို့ NOAC တွေပေါ်လာတဲ့အခါမှာကျတော့ဘာမှဒီ PTAPT ဒီကိစ္စသိမရှိဘူးဆိုရင် even rivaroxaban ဆိုရင် PT prolong ဖြစ်တတ်တယ်ဆိုတော့နည်းနည်းလေးသူမလဲပဲ problem တော့လုံးမရှိတာတော့မဟုတ် liver တွေနဲ့မလွတ်တာတော့မဟုတ်ဘူးရှိတော့ရှိတယ်ဒါပေမဲ့ NOAC ကို anticoagulant တင်မယ်ဆိုရင်အဓိကကတော့ renal failure ကိုပဲအမြဲတမ်းကြည့်တယ် mainly က creatinine clearance ကိုပို့ပြီးအရင် check လုပ်စေချင်တယ် liver နဲ့ renal နဲ့ဆိုရင် renal ကိုအရင် check လုပ်နောက်တစ်ခုကတော့ thrombocytopenia ရှိလားမရှိလားပေါ့အဲ့တော့ thrombocytopenia နဲ့ anticoagulant ဆိုရင်လည်းပဲအားလုံး guideline ကတော့ platelet count more than 50 ကျော်နေတယ်ဆိုရင်ဆရာတို့ you can use the therapeutic dose of anticoagulant whatever you use low molecular weight or the NOAC ပေါ့30နဲ့50ကြားတချို့ကလည်း30နဲ့50ကြားဆိုရင်တော့ you can reduce the dose of anticoagulant 50% တဝက် short လိုက်တော့ဘာလို့ဆို platelet count နည်းနေပြီနည်းနေတာကိုဆရာတို့က anticoagulant တင်ဖို့ကြိုးစားတယ်အမြဲတမ်းတော့ဟိုကျွန်တော်စောစောကလည်းပြောသလိုပါပဲ anticoagulant တင်တော့မယ်ဆိုရင်ကိုလူနာရဲ့ bleeding risk assessment ကခက်တော့ခက်တယ်ဒါပေမဲ့လည်းဆရာတို့ကိုလူနာဒီတွေးထွက်နိုင်လားကိုအမြဲတမ်းချိန်ရပါမယ် anticoagulant တင်တိုင်း bleeding risk ကိုအမြဲတမ်းဆရာတို့ assess လုပ်ပါကိုလူနာတွေးထွက်မဲ့အန္တရာယ်ရှိနေတယ်ဆိုရင်တတိထားပြီးတော့သုံးပါမသုံးနဲ့လို့ပြောတာမဟုတ်เนาะတတိထားပြီးတော့သုံးပေးဖို့ platelet count 30အောက်တချို့ခိုင်လဲ20အောက်ရောက်သွားပြီဆိုရင်တော့ဖြစ်နိုင်တဲ့ရွေးခဏ anticoagulant တွေကိုရပ်ထားပါလို့ပြောတယ် held လုပ်ထားပါပေါ့เนาะ20အောက်ရောက်နေတယ်အဲ့ဒါဆိုရင်ကျွန်တော်စီမှာလူနာရှိတယ် DVT လည်းရှိနေတယ် platelet အကလည်း1ပဲရှိရ DVT ကလည်းဒီတိုင်းမှာလည်း1000ကျော်နေတယ်ဒါ diagram ပဲ DVT ရှိနေတယ် platelet ကလည်း very low MDS လူနာ myelodysplastic platelet က refractory ဖြစ်နေတယ်ဘလောက် platelet ထဲမတက်တော့အဲ့တော့သူတို့ကတော့ platelet 20အောက်ဆိုရင်လုံးမတုံးရတော့ဘူးလား DVT ကလည်းတိတ်ရှိနေတယ် message လည်းဖြစ်နေတယ် PE risk နဲ့ပဲရှိနေတယ်ဆိုတော့အဲ့လိုအခါမျိုးမှာတော့သူတို့ကတော့ low dose low molecular weight heparin ကို you can use it ပေါ့အဲ့တော့စောစောက question လေးပဲပြန်သွားရမယ်ဆိုရင် liver case တွေက bleeding risk များပါတယ် coagulopathy မှာအဲ့တော့သူတို့ကတော့ oral နဲ့ low molecular weight heparin နဲ့ဆိုရင် low molecular weight heparin ကိုပို့ပြီးတော့သုံးစေချင်တယ်နောက် warfarin တဲ့ဆိုင်တော့ NOAC ကိုပို့ပြီးတော့သုံးစေချင်ပါတယ်ဆရာ dose တို့တော့ဆရာတို့ short ပါလိမ့်မယ်ထင်ပါ thank you
Thank you. General, in case of warfarin, we just the dose by INR and the clinical signs of bleeding. But in case of NOAC, it is a common thing. We don't use any. But is there anything over anticoagulation effect by using NOAC? We can have some the bleeding from NOAC. Can we have it? And do you have any? Yeah, we can. Literally, we can.
of course
In
of
that
course
case, for the case of warfarin, we usually reverse the anticoagulation by giving vitamin K.
yes
But in case of bleeding due to NOAC, how can we reverse the anticoagulant effect?
အဲ့ဒါတော့အကြောက်ဆုံးပါပဲပေါ့နော်သူကိုနိုင်ငံကို NOAC တွေဝင်လာတာလဲသဘောကျပါတယ်တနိုင်ငံတစ်ကမ္ဘာလုံးသုံးနေတဲ့ကိစ္စကိုနိုင်ငံဆရာဝန်တွေလဲသုံးကြည့်ရမှာပဲ problem ကတော့ NOAC တွင်တဲ့ company တိုင်း antidote မပါလာဘူးကျွန်တော်တို့စီမှာ dabigatran original ရှိတယ် rivaroxaban original ရှိတယ် epic7 original က off label နဲ့အောက်မှာ outline နဲ့တွင်းနေတယ် original တမှာ register လုပ်မထားဘူးအခု ABC ဒီ epic7 ကဒါ first register လုပ်ပြီးတော့တရားဝင်တွင်းတဲ့ဆေးပေါ့သုံးမျိုးစလုံးရှိနေတယ်သုံးခုစလုံးနဲ့ဆရာတို့သုံးလို့ရတယ် problem က dabigatran အတွက် antidote ဖြစ်တဲ့ intarabezumab မရှိဘူး dabigatran တွင်းတော့ကသူတို့ antidote တွင်းပေးမယ်လို့ပြောတယ်မတွင်းဘူးအဲအကြောင်းနေရှိတယ် the X feta 10 inhibitor နှစ်ခုစလုံးတွေ antidote မရှိသေးဘူးကျွန်တော် India colleagues တွေနဲ့လည်းမေးကြည့်ပါတယ်ဆိုတော့ even India တော့မှပေးတဲ့လို့မကုန်သေးလို့သူတို့ဈေးသက်တာတွေဟာမထုတ်နိုင်သေးဘူးသူတို့စီမှာလည်း original dabigatran အတွက်ပို့ဆေးတွေရှိတယ် averasizumab original ပဲသုံးတယ် X ဒီ feta 10 inhibitor များအတွက်လည်း atazelet concentrate activated feta 10 concentrate လို့ခေါ်တာပေါ့နော်ဘာလို့ဆိုဒါတွေအားလုံးက10 inhibitor ဆိုတော့ antidote ကဘာလဲ main 10ပဲအဲ့တော့ feta 10ပြန်ပေးရုံပဲအဲ့တော့အဲ့ဒါမရှိပေးစရာမရှိတော့ဖြစ်လာရင်ဘယ်လိုလုပ်မလဲဆိုတော့ဖြစ်လာတယ်တွေ့တယ်မျက်စိရှင်းမှလည်းဖြစ်လာတယ် ICH တွေရတယ် GI bleeding တွေရတယ် NOAC တွေတောက်ပြီးတော့အဲ့လိုတွေဖြစ်လာရင်ဘာဆက်လုပ်ကြမလဲဆိုတော့တကယ်တမ်းကတော့ FFP is not recommended လို့သုံးတယ် warfarin မှာ recommended ရတယ်ဒါတော့ warfarin အတွက်ကျွန်တော်တို့ကအဲ့တော့ကျွန်တော်လိုချင်နေတဲ့ PCC လို့ခေါ်တဲ့ prothrombin complex concentrate အဲ့ဒါကိုကျွန်တော်ရဖို့ကြိုးစားနေတယ်ပေါ့နော်တစ်ဖက်ကဒါဒီဆေးရုပ်ကင်သုံးပြီးတော့ bleeding လည်းရှိရောဘာမှလုပ်လို့မရတော့ဆရာ no antidote FFP are not effective အဲ့တော့သွေးတိတ်ဆေးပေးထားရင်ကလွယ်ရင်ဘာမှလုပ်လို့မရအောင် FFP ကသုံးမိတာသုံးနေရတာတကယ်တမ်းတော့ effective မဖြစ်ဘူး DOAC bleeding တွေအတွက်အဲ့တော့ DOAC bleeding ကကျန်တဲ့ hemostatic effect တွေသွေးတိတ်ဆေးတွေပေးဖိလို့ရရင်ဖိထားအဲ့ပြီးတော့ charcoal ဆိုတာတော့ကျွန်တော် surgeon colleague တွေနဲ့ဆိုတော့ charcoal ရှိတယ် oral charcoal သုံးလို့ရတယ်အဲ့တော့ oral charcoal ကလည်း episode နဲ့ rivaroxaban ကဆေးတောက်ပြီး6နာရီနဲ့8နာရီအတွင်းဆိုရင်ပေးလို့ရတယ်ဒါပေကတွင်ဆို2နာရီအတွင်းမှာ2နာရီကျော်ရင်ပေးလို့မရဘူးတို့ရဲ့ associated bleeding ဆိုရင်တော့သူတို့မေးတာကဘယ်တော့မှနောက်ဆုံးတောက်ထားလဲဆေးကိုဒါပဲပေါ့ဒါပေမဲ့ဆိုတော့ကံကောင်းတဲ့အချက်တွေကတော့လုံးမလို့ကြလာဝဲ heparin အတွက် protein ရှိတယ်ဒါပေမဲ့လေတို့ဘက်ကလည်းဘယ်တော့မှနောက်ဆုံးတောက်ထားတယ်လေကံကောင်းတဲ့အချက်ကတော့သူ့ effect ကသူ့အနေနဲ့သူပြီးရင်ကုန်သွားလိမ့်မယ်အဲ့ဒီမကုန်ခင်ဖျားတပြီးစောင့်နေအဲ့ဒါပဲကျွန်တော်တို့ပါဒီ bleeding နဲ့ဟိုအဲ့ဒါတခုကကျွန်တော်တို့မှာတကယ် weak point ကြီးဖြစ်နေပါသေးတယ်လောလောဆယ်ဆရာပြောသလိုပဲတို့ရဲ့ associated bleeding ဒီတကယ်ကို check လုပ်မှာတော့အာသာကို morbid တွေရှိနေသလားဘယ်တော့မှနောက်ဆုံးတောက်ထားတယ်လဲ bleeding ဘယ်လောက်များတယ်လဲဘယ်လောက်အရေးကြီးတယ်လဲ critical area မှာရှိတာလားရှိရင်ဆိုရင်တော့ဆရာတို့အကုန် blood concentrate ကိုထည့်ပြီးသုံးပါပေးစရာမှမရှိသေးတာ FFP ပဲပေး PCC ကျွန်တော်တို့ဆီမှာမရှိဘူးသူတို့ကတော့ FFP မရှိရင် PCC သုံးပါလို့ပြောတယ် PCC နဲ့ antidote နဲ့ပေါ့နော်ဒိုဝက်ကိုရက်လိုက်အချိန်ကတော့ဒီဒိုဝက်တွေအားလုံးရဲ့ half life တွေအားလုံးဟာ6 to 12 hour ကြာတယ်တခါလေတစ်ရက်ကြာတယ်အဲ့တော့ကျွန်တော်တို့ကဒိုဝက်တောက်ထားတဲ့လူတွေ emergency ခွဲမယ်ဂျုံတိုင်းခွဲဖို့စိတ်ဖို့လိုလာပြီဆိုလို့ရှိရင်နောက်ဆုံးဒိုဝက်ဘယ်တော့မှတောက်ထားတယ်လဲ within 12 hours ဆိုရင် risk ကနည်းနည်းလေးတော့များတယ်စောင့်လို့ရရင်ခဏစောင့်တကယ်တမ်းဒိုဝက်အားလုံးရဲ့ principle ကတော့မခွဲခင်တစ်ရက်ခွဲပြီးတစ်ရက်အဲ့ဒါရရမှာပဲဒါ peri operative ကဆရာတို့လုပ်မယ်ဆိုရင်အဲ့တော့တကယ်တော့နည်းနည်းခက်တယ်ဆရာ antidote ကတော့ဆိုတော့ဟို radiologist ဖြေတယ်လို့ပဲ India က you have to do it antidote in India you have the original one yeah
We do have proximate. For dabigatran, we do have that antidote. Antaxant alpha yet to come, sir. There is only one company, original one only. There are no biosimilars available, very expensive. In Indian money, it costs around, say, maybe in US, I can say, around $3,000. It will call US dollars. But one thing interesting is the company which markets dabigatran, the products are, they are ready to give it Praxibine free of cost. When we are giving products, the same patient develops the need. When we inform the company, they give the Praxibine free of cost, but it is very expensive.
Thank you, good professor, for your very valuable question. Because recently I have a very bitter experience of losing one patient, not my personal, but my colleagues. Patient passed away because of the uncontrolled GI bleeding. So this is a very sad story. So that's why so the point is that although they said the bleeding risk is minimal, there still is a risk, and we need to have an expert treatment opinion, like our Professor Tunlunye. We need to have a special consultation, special management from him, or other available hematologists. The point now next question. Actually, there are several questions, but to make our question time shortened, I will combine two questions regarding the atrial fibrillation because we have cardiologists, renowned cardiologists. When the first question is, why do we still need to take anticoagulant even after AF ablation or atrial appendage closure? Will it suffice for the aspirin alone in this case? So atrial fibrillation, anticoagulant, even after the ablation of AF, do we still need to use anticoagulant?
Okay. Very, very nice question. I don't know, whoever thinking, must be a cardiologist, I think. The point is, I have a atrial fibrillation, I have reverted it by a catheter-based ablation. Do I have to give anticoagulation? The answer is unfortunately yes. The reason is, people who develop, like as I said initially, atrial fibrillation is not the indication of anticoagulation. Atrial fibrillation with a significant Chadwick score. So there should be other traits, other risk factors which makes him prone to develop stroke and system embolism. That is worth giving anticoagulation with the risk of bleeding. So after AF ablation, all the other risk factors are going to persist. Like I don't cure diabetes or hypertension or congestive cardiac failure most of the time after an ablation. Number two is, even though we ablate, a good number of patients are known to have recurrence. By international standards, even the best center in the world would do routinely, there's around 30 to 40% recurrence, number two. Number three is, even after making the ablation to go away, maintain sinus system, the atria remodeling doesn't disappear immediately. The atrial myopathy persists. So thrombogenicity of the left atrium or the left atrial appendage continue to persist. So for these reasons, almost all the patients, we continue anticoagulation indefinitely. There are some new data emerging where we can stop after a period of 12 months to 24 months, but too early to come to a conclusion or as a recommendation. So as of today, patients who have atrial fibrillation, who satisfy Chadwick's criteria for anticoagulation, you need to continue even after ablation and reverting back to sinus system.
Yeah, thank you. There are still many questions. However, in the interest of keeping the time, we already 9 minutes overshoot. I will ask the last question regarding the AF. In the case of prosthetic valve, a patient having prosthetic valve, why DOAC is not choice? Any explanation?
Yeah, explanation is a good question. I mean, the challenge is thought was occurring to us. Patients who have a prosthetic valve, particularly we are talking about metallic valve. Bioprosthetic, I have answered previously itself. Whether metallic valve or a moderate to severe mitral stenosis, the hypothesis, we have to prove it. Hypothesis, we need an anticoagulant which is a multi-pronged approach. Like our speaker beautifully showed the virtuous triad and other things, how it hits. A person who has got a rheumatic heart disease, mitral stenosis, LEA histology changes, or a prosthetic valve, we would like to have an anticoagulant which is potent, which is going to have a multiple pathway to increase the heightened risk of thromboembolism of the valve and thing. That's the only explanation we have. And data, like we are quoting about all the seminal articles, the major trials and smaller trial which follow like NVAL or RIVER, everywhere we realize using anticoagulation in metallic valve is not indicated.
Yeah, in conjunction with the cardiovascular, when the cardiovascular is not done, or even if it is done, it is not successful, should anticoagulants be given lifelong in case of, yeah.
Yeah. 2 points. Number one is I come across a patient with atrial fibrillation. It was acute. I'm going to cardiovert. I need to do 2 things. Whether the tachycardia, the AFib is less than 48 hours. In that case, I can even go ahead and anticoagulate. If it is more than 48 hours, I can't anticoagulate because there's a sufficient time for a LA thrombus to form. So you need to anticoagulate him for a period of 3 weeks. An adequate INR or a standard good dose of NOAC. Then only you should think of cardioversion. One escape route is do a TE, do a transesophageal echocardiogram. If the LA appendage, as I showed, if it is free of clot, you can go ahead and cardiovert. But after cardioversion, 4 weeks of anticoagulation compulsory. Third point is, as sir rightly asked, After cardioversion, irrespective of type of atrial fibrillation, if the CHA2DS score is significant, you will have to continue anticoagulation for lifelong. Whereas the young person who comes with the first time due to some other reason, CHA2DS score 0 in men or 1 in women, you can consider stopping anticoagulation after a period of 4 weeks. Otherwise, you do that. So the mantra is look at the CHA2DS score with atrial fibrillation. And
Yeah, thank you. Last. One question is the patient with unilateral leg swelling and D-dimer was found to be more than 10,000 and Doppler ultrasound leg, no DVD. So what's your opinion, sir?
According to the guideline, if the Doppler ultrasound is negative, you should look for the other causes of the risk D-dimer. Do not need to treat as a DVD.
Yeah, Professor Tununji has already discussed about it.
အဲ့လောက်တာပါတပတ်နေရင်ပြန်ရိုက်ပါသူတို့ခိုင်လိုက်ရဆရာတို့တစ်ခေါက်သေးရိုက်လို့ negative ဖြစ်တာနဲ့ you cannot exclude ဒီတိုင်းမှာဆရာတို့ clinical science symptom က very strong suspicious of ဆိုတော့ပြောတဲ့ clinical probability score က high ဖြစ်နေတယ်ဆရာတို့ think of DVT ဒီတိုင်းမှာလည်းတက်နေတယ် ultrasound ရိုက်လိုက်တဲ့ Doppler negative တို့ပြန်လာတယ်ချက်ချင်းကြီးမရပါမလုပ်ပါနဲ့တင်စရာရှိတဲ့ anticoagulant ကိုဆရာတို့စထားပါတပတ်နေပြန်ရိုက်ပါသူတို့ guideline တိုင်းပဲကျွန်တော်လည်းခဏခဏကြုံဘူးတယ်နောက်တစ်ပတ်နေပြန်ရိုက်ရင် DVT ထွက်လာတယ် positive ပြန်ဖြစ်သွားအဲ့တော့သူတို့ရဲ့ guideline ကတော့တပတ်နေပြန်ရိုက်ပါ other causes ဆိုလည်းရှာပါ that's true ပါနော်
The problem is affordability and the accessibility to the DVD. The problem. However, we still have, although we still have some more questions, in terms of, for the interest of saving time, keeping time with the allotted hours, we have already overshoot 15 minutes, so I'm afraid we have to stop here. I do need to apologize to those persons who has already raised a question and we cannot answer the question. We will give it to the committee and they will give to the relevant speakers or the chairperson. They will get back to you in the written form, answering your question. So that will, I believe that will satisfy you. Although we cannot answer here right now in this live symposium. So thank you very much. I have to thank Professor Murali, Professor Minsowin, Professor Damien, Professor Tununye, and Professor Anjodu, all the chairperson, all the speakers for your excellent talk, excellent moderation of this session, and all the speakers for your active listening and for raising very practical and very useful questions. So which make the symposium very lively and very a very useful one. So I believe that we have spent here nearly more than 3 hours, and I think that 3 hours will certainly benefit you for your clinical practice. Thank you very much. Then I would like to hand over the floor back to MC for the continuation of the ceremony.
မိကုများကိုအသေးစိတ်ဆွေးနွေးပေးသွားတဲ့ chairperson နဲ့ speaker များကိုအထူးပင်ကျေးဇူးတင်ရှိပါတယ်။အစီအစဉ်17အရာ ABC International Company Limited မှ Group Product Manager မက်ချုံမေသိန်းမှ ABC အပီစာပန်အကြောင်းပြောကြားပေးမှာဖြစ်တဲ့အတွက်မက်ချုံမေကိုစင်ပေါ်သို့ဖိတ်ခေါ်ပါရရှင်။
ကြောက်လာရဆရာကြီးနဲ့အမတို့အားလုံးပဲမင်္ဂလာပါရှင်ညီမကတော့ ABC International ရဲ့ Group Program Manager ချုံမေဖြစ်ပါတယ် ABC အပြည်စာပန်းအကြောင်းလည်းပြောခင်မှာညီမတို့ကုမ္ပဏီအကြောင်းနဲ့အနေငယ်မိတ်ဆက်ပေးချင်ပါတယ်ရှင်ညီမတို့ကုမ္ပဏီက quality ကောင်းမွန်တဲ့ product တွေကို marketing ရော distribution ရော service ပေးနေတဲ့ကုမ္ပဏီတစ်ခုဖြစ်ပါတယ်ဒါအပြင် ISO 9001 2015 လက်မှတ်ရထားတဲ့ကုမ္ပဏီတစ်ခုလည်းဖြစ်ပါတယ်ရှင်ညီမတို့ကုမ္ပဏီဟာဈေးရဆိုရင်တကယ်လဲ novel ဖြစ်ရမယ် effective ဖြစ်ရမယ်ညီမနိုင်ငံမှာရှိတဲ့ patient တွေအကုန်လုံးတက်နိုင်တဲ့ဈေးနှုန်းဝန်းကျင်မှာဖြစ်ရမယ်ဆိုတော့ရည်ရွယ်ချက်၃ချက်နဲ့ဈေးတွေကိုအဓိကတင်သွင်းပါတယ်ရှင်အခုဆိုရင်ညီမတို့ကုမ္ပဏီအားဆိုရင်ညီမနိုင်ငံမကတ်မှာလိုအပ်နေတဲ့ဈေးဝါးတွေ product တွေကိုလည်းအဓိကဖြည့်ဆည်းပေးနိုင်မှုအတွက်ရည်ရွယ်ပါတယ်ရှင်ဒါကတော့ညီမတို့ကုမ္ပဏီနဲ့လက်တွဲပြီးလုပ်နေတဲ့ business partner တွေဖြစ်ပါတယ်ဒီမှာဆိုရင်အာတနီညာအခြေဆိုင် Bago Principal Pakistan အခြေဆိုင် Ferozam India အခြေဆိုင် Hetro ICBA NACO စတဲ့ business partner group နဲ့လက်တွဲပြီးတော့ quality ကောင်းမွန်တဲ့ product တွေကိုတင်သွင်းပေးနေရဖြစ်ပါတယ်ရှင်ညီမတို့ကုမ္ပဏီကို2016ခုနှစ်တည်းကစပြီးတော့တင်သွင်းခဲ့ရပါအခုဆိုရင်နှစ်ပေါင်း9နှစ်ရှိပါပြီဒီနှစ်ပေါင်း9နှစ်ဝန်းကျင်မှာဆိုညီမတို့ product ပေါင်းအမျိုးပေါင်း200ကျော်တင်သွင်းဖြန့်ချိလျက်ရှိပါတယ်ရှင်မြန်မာနိုင်ငံကိုပထမဆုံးအကြိမ်နဲ့တင်သွင်းလာတဲ့ oral anticoagulant တစ်ခုဖြစ်တဲ့ ABC အပီစာပန်းနဲ့မိတ်ဆက်ပေးခြင်းပါတယ်ရှင် ABC အပီစာပန်းကအပီစာပန်း 2.5 mg ပါဝင်ပါတယ်သူဟာဆိုရင်သူ့ရဲ့ packaging လေးကတော့10လုံးပါ3ကနဲ့လာပါတယ် American College of Cardiology နဲ့ American Heart Association ကနေပြီးတော့မှ recommendation ရထားတဲ့အပြင် USFDA ကနေပြီးတော့မှ approve ရထားတဲ့ molecule တစ်ခုဖြစ်ပါတယ်ရှင်ညီမတို့ ABC အပီစာပန်းဟာဆိုရင် Ferritin ကိုပဲ selectively inhibit လုပ်တဲ့ oral anticoagulant တစ်ခုဖြစ်ပါတယ်ရှင်ညီမတို့ရဲ့ ABC အပီစာပန်းဟာဆိုရင် original brand ဖြစ်တဲ့ Eliquis နဲ့ရှင်မယ်ဆိုရင်လည်း bio equivalent ဖြစ်တာကိုတွေ့ရပါတယ်ရှင်ညီမတို့ရဲ့ ABC အပီစာပန်းကို MVA ကြောင့်ဖြစ်တဲ့ stroke ကို prevent လုပ်ဖို့ရယ်Total hip and knee replacement surgery မှာ Thromboembolism ကို prevent လုပ်ဖို့ရယ် DVD နဲ့ PE kit တွေမှာ treatment အနေနဲ့ရော prevention အနေနဲ့ရောညီမတို့ရဲ့ ABC အပီစာပန်းကိုအသုံးပြုပေးလို့ရပါတယ်ရှင်ဒါကတော့ညီမတို့ရဲ့ ABC အပီစာပန်းနဲ့တခြားသော oral anticoagulant တွေဖြစ်တဲ့ rivaroxaban, dabigatran နဲ့ direct comparison လုပ်ထားတဲ့ချက်လေးဖြစ်ပါတယ်။ဒီမှာဆိုရင် ABC အပီစာပန်းရဲ့ထူးခြားချက်က renal excretion အနည်းဆုံး anticoagulant ဖြစ်ပါတယ်။ renal excretion က 28% ပဲရှိတဲ့ကြောင့်မလို့ renal impairment patient တွေမှာဆိုရင် dosage adjustment ပေးစရာမလိုဘဲနဲ့ပေးလို့ရပါတယ်။ warfarin နဲ့ရှင်မယ်ဆိုရင်လည်းညီမတို့ရဲ့ ABC အပီစာပန်းဟာဆိုရင် stroke ရော systemic embolism ဖြစ်နှုန်းကအနည်းဆုံးဖြစ်တဲ့အပြင် GI bleeding risk ကလည်းအနည်းဆုံးဖြစ်ပါတယ်ရှင်။ညီမတို့ရဲ့ ABC အပီစာပန်းကို MVA ဆောက်ဖြစ်တဲ့ stroke နဲ့ systemic embolism ဖြစ်နှုန်းကိုလျှော့ချဖို့အတွက်ဆိုရင်တော့5 mg ကို BD ပေးလို့ရပါတယ်ရှင်။ညီမတို့ရဲ့ ABC အပီစာပန်းဟာ 2.5 mg ပါဝင်တဲ့ကြောင့်မို့တကယ်လို့ပေးမယ်ဆိုရင်တော့မနက်လုံးညလုံးပေးဖို့ရလိုအပ်ပါတယ်ရှင်။အကယ်၍ patient ကအသက်80နဲ့အထက် body weight က60 kg အောက် creatinine က 1.5 mg မှာ deciliter အထက်ဖြစ်ခဲ့မယ်။အဲ့ဒီ3ချက်ထဲက2ချက်နဲ့ကိုက်ညီခဲ့မယ်ဆိုရင်တော့dosage ကိုချော့ပေးဖို့ရလိုအပ်ပါတယ် 2.5 mg BD ပေးလို့ရပါတယ်ရှင် DVD နဲ့ PE treatment kit တွေမှာဆိုရင်တော့ပထမ9ရက်မှာ10 mg BD ပေးလို့ရပါတယ်နောက်ပိုင်း9ရက်ကြာရင်တော့5 mg BD ပေးလို့ရပါတယ် recurrent risk ကိုလျှော့ချဖို့အတွက်ဆိုရင်တော့ 2.5 mg BD ပေးလို့ရပါတယ် hip replacement therapy မှာဆိုရင်တော့ ABC အပီစာပန်းဟာကို2.5 mg ကို BD နဲ့35ရက်ပေးလို့ရပါတယ် knee replacement therapy မှာဆိုရင်တော့ 2.5 mg ကို BD နဲ့12ရက်ပေးလို့ရပါတယ်ရှင်တခြားသော anti-coagulant တွေဖြစ်တဲ့ rivaroxaban, dabigatran ကနေပြီးတော့မှ ABC အပီစာပန်းကိုပြောင်းပြီးသုံးမယ်ဆိုရင်လည်း drug transition လုပ်ရတာအရန်ကိုလွယ်ကူပါတယ်တကယ်လို့ warfarin 300ကနေပြီးတော့ညီမတို့ရဲ့ ABC အပီစာပန်းကိုပြောင်းပြီးတော့သုံးမယ်ဆိုရင်တော့ INR less than 2 pp ဆိုတာနဲ့ညီမတို့ ABC အပီစာပန်းကိုပြောင်းပြီးတော့သုံးလို့ရပါတယ်တကယ်လို့ dabigatran, rivaroxaban ကနေပြီးတော့မှ ABC အပီစာပန်းကိုပြောင်းပြီးတော့သုံးမယ်ဆိုရင်တော့ next schedule dose မှာတင် ABC အပီစာပန်းကိုပြောင်းပြီးတော့ပေးလို့ရပါပြီရှင်ညီမတို့ရဲ့ ABC အပီစာပန်းဟာထူးခြားချက်ဟာဆိုရင် aspirin နဲ့ရှင်မယ်ဆိုရင်bleeding risk လည်းအရင်နေပါတယ် warfarin နဲ့ရှင်မယ်ဆိုရင်လည်း efficacy ရော safety ရောပိုကောင်းပါတယ်နောက်ပြီးတော့ laboratory monitoring requirements ကလည်းအများကြီးမလိုပါဘူးဒါကြောင့်မို့ follow up လုပ်ရတဲ့ပမာဏကလည်းအချိန်အတွက်ကလည်းနည်းပါတယ် နောက်ထပ်အားသာချက်တစ်ခုကတော့ဈေးနှုန်းမှာညီမတို့ရဲ့ ABC ပီဇာဘန်ရဲ့ဈေးနှုန်းကဆိုရင်တစ်လုံးကို600ကျပ်ပဲရှိပါတယ်။ဒါကြောင့်မို့ခြားသော oral anticoagulant နဲ့ရှင်မယ်ဆိုရင်ဈေးနှုန်းက2ဆလောက်နီးပါးအသာတာကိုတွေ့ရပါတယ်။ဒါကြောင့်မို့ patient တွေလည်း cost effective ဖြစ်တာကိုတွေ့ရပါတယ်ရှင်။ညီမတို့ရဲ့ ABC ဘန်ဟာဆိုရင်ဈေးနှုန်းသက်သာတဲ့အပြင်မှာ side effect လည်းနည်းတဲ့ကြောင့်မို့တကယ်လို့တင့်တော်တဲ့ patient profile လေးများရှိမယ်ဆိုရင်တော့ ABC ဘန်နာမည်နဲ့ prescribe လုပ်ပေးဖို့ request လုပ်ပါတယ်ရှင်။အားလုံးကိုကျေးဇူးတင်ပါတယ်ရှင်။
ကျေးဇူးတင်ပါတယ်ရှင်အစီအစဉ်12အရာအမှတ်တရလက်ဆောင်များပေးအပ်မှာဖြစ်ပါတယ်အမှတ်တရလက်ဆောင်ပေးရရန်အတွက်ဦးစွာ Professor မြင့်စိုးဝင်းအားအမှတ်တရလက်ဆောင်ပေးရရန်အတွက် Professor ခင်မေဆန်းကိုဖိတ်ခေါ်ပါတယ်ရှင် And then, may I invite Mr. R.C. Yadav to give memento gifts to our another two chairperson. So, may I call upon Professor Utin Suila. May I call upon Professor Ton Linye? Thank you very much, Mr. R.C. Yadav. Now, may I invite Mr. Rajiv Rawal to give memento gift to Professor Tia Muralidharan. Thank you, Mr. Rajiv. Now, may I invite Mr. Dinesh Gadrel to give memento gift to Professor Utaigne. Thank you, Mr. Dinesh. Professor Auto Chodua, ABC International Limited မှာအမှတ်တရလက်ဆောင်ပေးရမှာဖြစ်တဲ့အတွက်ဦးစွာ Matt Demala ကိုဖိတ်ခေါ်ပါရရှင် Professor Auto Chodu အစား ABC International မှာ Matt သိန်းစုနှစ်မြတ်လွင်မှာလက်ခံပေးမှာဖြစ်ပါရရှင် Thank you, Madamala. Now, may I invite Mr. Rajiv Rawal again to give memento gift to Mr. R.D. Yadav. Thank you, Mr. Rajiv. Now, may I invite Mr. Dalit Radho to give moment to give to NetGo Farmer. May I call upon Mr. Venkata Sandhya to receive moment to give on behalf of Mr. Sita Alabadi. Jesus Marishan, Season Salaya, ABC International Company Limited Ma, Executive Director, Mr. Dinesh Gadgwema, Pink Maska Pare. May I invite our Executive Director, Mr. Dinesh Gadgwema, for saying vote of thanks.
Good afternoon, ladies and gentlemen. I feel honored and privileged to get the opportunity to propose a vote of thanks on this special event. As the afternoon unfolded and blossomed, we all traveled through this wonderful session. I call that an island of learning. So thank you so much. I, on behalf of ABC International, convey deep regards and heartfelt thanks to honorable chairpersons, speakers, for taking the time out of their busy schedule and sharing their perspective with this august audience. I would like to convey my heartfelt thanks to our chairpersons, Professor Mesoven, Professor Tinsula, Professor Tulin for their rich and razor-sharp inputs, which were enriching in content and medical wisdom. My special thanks to Professor Muralidharan, who traveled all the way from Chennai, India, exclusively for this event, for sharing his perspective while drawing inference from various global data on prevalence of atrial fibrillation. I would like to convey my hearty thanks to Professor Theme for sharing his observation on clinical management of thromboembolism. I express my hearty thanks to Professor Ong Chathu, who joined us online for his presentation on art of anticoagulation. I would like to express my hearty thanks to all the respected doctors who took their time to attend this seminar in person, and those approximately 250 of those who joined online. Thank you so much. I sincerely believe that they would have found this session very enriching. My special thanks to Mr. R.C. Yadav, Counselor, Indian Embassy, for taking his time out and sharing his thoughts on contribution of Indian pharma industry on global health. My special thanks to Netco Pharmaceuticals, our partner in bridging therapy gaps in Myanmar by providing quality pharmaceuticals. I would like to convey my sincere thanks to all my fellow colleagues in ABC who have worked tirelessly to making this event a success. Team, your seamless planning and flawless organizing this event. We are indeed privileged to have you as a professional team of colleagues. We are indeed blessed to have you all. Thank you so much. Have a nice day.
Thank you.